Good morning. You all are welcome to the pre-Congress workshop of 19th annual academic sessions. According to the new normal, we are going to have this in hybrid setup with online lectures. So we have 5 centers. The main center is in Lanka Hospital and another 4 centers in Jaffna, Batticaloa, Peradeniya and Galle. So idea of having a workshop is to upgrade the knowledge of our colleagues. So this time we have selected the topic on obstetric imaging, where it's mostly outgoing from the radiologist. However, we face challenges when it comes to the problem cases to VOGs. Invariably, they are going to send the patient for the assistance with the radiologist to clarify the problems. So therefore, we have to be very careful and very competent on obstetric imaging sometimes than the VOGs. So we invited a renowned speaker from India to do the lectures on this setup. He is Dr. Chander Lulla. He's a consultant zonologist and fetal medicine specialist. He's a graduate from India and did his postgraduate as well in India. He's a consultant zoologist in RIA Clinic, Mumbai, and he's a consultant zoologist in Jaslock Hospital, Mumbai, as well as he's a consultant zoologist in Reliance Hospital, Mumbai. He has got awarded awards and achievements as a counselor for Asian Federation of Ultrasound in Medicine and Biology. That's called AFSUMB, and he's the ex-president of Indian Federation of Ultrasound in Medicine and Biology, as well as he's the ex-editor of the same Indian Federation of Ultrasound in Medicine and Biology of its journal. It's a part of an Asian Federation and European Federation of Ultrasound in Medicine and Biology. He's a current dean in Indian Federation of Ultrasound in Medicine and Biology. And he's an ex-ambassador for India for ISUG, that is International Society of Ultrasound in Obstetric and Gynecology. He has got many publications, many presentations and lectures throughout India and internationally, conferences and journals and books. Okay, so we welcome Dr. Chander Lulla, and over to you, sir.
Thank you, Dr. Pangla, and I thank the Sri Lankan College of Radiology for inviting me. It's an honor in these times to be part of your annual Congress workshop. We are going to do 4 lectures on first trimester, second trimester, multiple pregnancies and interventions with some videos on the way. And I'm sure there will be question and answer sessions. So I will share my screen now. Can you see my screen? Can you see my screen?
Yes, we can.
Okay. So when we talk of genetic evaluation, we just heard from your president that we are competing with the OBGYN colleagues when we're dealing with obstetric ultrasound, and that's a global phenomena, and we need to be upfront in all our knowledge and technologies. So as you know, there is a lot of explosion of technology today in terms of biochemistry, genetics, and even ultrasound. So we have changing biochemical scenario, as you can see here, from combined screening to NIPT. Genetics has changed from the basic fish karyotype to using rapid tests like the QFPCR microarray, and on the horizon is the next generation sequencing, whole genome, etc. And keeping pace with all of that is ultrasound technologies. Now, when we talk of first trimester ultrasound screening, we must look at the Carnegie stages of development from 10 to 23. where it gives us good insights into development. But today we're not going to talk about embryology. We are going to straight away jump into genetic evaluation of ultrasound. So will the explosion of technologies in terms of molecular and other technologies, biochemical technologies, make ultrasound redundant? Not really so, and I hope to persuade you otherwise that expert sonography and fetal imaging is going to maximize the benefits of all these technological advances that we see in molecular diagnosis, and therefore we must be well abreast with these technologies. Now, when we talk of congenital abnormalities, genetic or other etiologies, we basically have three groups. One is the malformation, which is an intrinsic developmental abnormality, something like an abnormal heart, congenital heart, cleft lip, or polydactyly. Then we could have a deformation, that is a mechanical force, something like oligohydramnios causing clubfoot, or a Pierre-Robin sequence leading to cleft palate. And then the third could be a disruption where the developmental process is disrupted by something like an amniotic band sequence. So when we look at congenital abnormalities, 3%, 1 to 3% can be identified by prenatal imaging, and standard genetic tests can identify about 30% of the cause. In 70%, the cause remains yet unknown, and new technologies help us in unraveling the secrets there. The prevalence of Down syndrome in our country, and I suppose in the Asian subcontinent, is about 1:900, and at least 3 Down syndrome children are reported to be born every year. Now, we all know that a lot of our congenital abnormalities undergo spontaneous demise. So almost 2/3 of early embryonic demise and 1/3 of miscarriages in the first trimester, as you can see here, are due to chromosomal abnormalities. And so also 5% of stillbirths, 5% of infant deaths can all be due to chromosomal abnormalities. And this is more common with repeated miscarriage and multiple structural abnormalities. And therefore, very important that when you have a miscarriage, we must analyze the products of conception. As you can see here, we have an autosomy in the chromosome 2 here, trisomy 2, which is responsible for the genetic abnormalities in these products of conception. So before I embark upon first trimester screening, just a review of genetics for our basic review. The types of chromosomal abnormalities, as you know, we deal with are numerical. So we can have a missing chromosome, something like 45XO, or an extra chromosome, something like an aneuploidy or trisomy 21, 18, or 13. There could be a mosaic pattern, which involves mixing of many cell lines. We could have structural malformations in the form of microdeletions and duplications or translocations, and these are important. And then there could be de novo mutations. When we look at Mendelian inheritance, it's very important that when we look at a genetic disorder, we must know what is the inheritance, because we need to counsel the parents as to what is the recurrence rate. So if you have an autosomal recessive Mendelian inheritance, then there is a 25% recurrence rate. When we have an autosomal dominant inheritance, we have a 50% recurrence rate. And if it is an X-linked inheritance, as you know, the males are the sufferers, and it's about a 50% recurrence rate involvement of the male out there. So, and then we have 3 types of Down syndrome, as you know. We have the classical type of Down syndrome, which is the non-disjunction, where you have 3 sets of chromosome 21. This is about 95% of cases. Then we have translocation, where one chromosome, a bit of one chromosome goes to the 21 chromosome, and this is about 4%. And then there is a mosaic cell line, so you have multiple types, and these are about 1%. Now, why I'm telling all this is because many parents are carriers. They are carriers of balanced translocation genomic content. So a small portion of genetic material is rearranged from one chromosome to the other, and these are commonly involving chromosome 13, 14, 15, 21, and 22. And they can lead to either a normal phenotype and recurrent miscarriage and genetic abnormalities in the offspring. So that's why it's very, very important that we have the parental karyotype when we see an abnormality in the fetus. So when a mother or a father has a balanced translocation, the child may inherit either normal chromosome, they may inherit the balanced translocation, or it may become unbalanced, and then there will be abnormalities in the child, or the pregnancy may end in miscarriage. So these are the problems of balanced translocations. Now, the very important question is, what is the recurrence of any genetic abnormality, for example, Down syndrome, when you got a previous child with Down syndrome? The recurrence is usually 1%, but it again depends on what is the parental karyotype, as I said. So if the mother is a balanced translocation, then the recurrence is about 1 in 8. If the father is a balanced translocation carrier, then the recurrence is usually 1 in 40. And if the balanced translocation is from chromosome 21 to 21, then the recurrence risk is about 100%. So this is very, very important that when we have a previous history of a child with Down syndrome, we must look at the parental karyotype. Now, when we look at overall genetic involvement, before 2013, if we analyze our results, almost 64% of our genetic abnormalities were aneuploidies or trisomies, 13, 18, 21. But after 2013, when we started doing microarrays, chromosomal microarrays, we realized that there were a lot of other abnormalities, especially structural abnormalities in the form of deletions and duplications, and this resulted in their numbers going up. So the actual involvement of genetic abnormalities in the form of trisomies came down to 50% because the other abnormality numbers started increasing. So we need to enrich ourselves with the knowledge of what these structural malformations are. Now, what is the role of the fetal medicine expert? The role of the fetal medicine expert when the baby is having an abnormality, these are the 4 standard questions that all parents will ask you. Of course, they will ask you, what is wrong? Is my baby, for example, you tell the parents you have a choroid plexus cyst, the first question will be, is my baby mentally retarded? So what is the diagnosis? Then the next question is, what is the prognosis? Is there any hope of this pregnancy continuing? If you've got mild pileectasis, there is good prognosis. And the third question they always ask is, why did it happen? So what is the reason? Is there a viral infection? Is there something else? And the last question is, of course, recurrence risk. So that I've already enlightened that what is the recurrence risk. Now, who is at risk? All pregnancies are at risk, as we know, and you can see that in the early 1980s, we used to say that only mothers above 35 are at risk, but these were only risk for aneuploidy, like trisomy 21. But today, if you see the other genetic defects, as I said, structural abnormalities, deletions, duplications, highlighted in orange here, these are all pervasive and can occur at any age. So any woman who's pregnant can be at risk, especially it could be a de novo mutation, or she could be a carrier of a particular gene. So the risk of genetic abnormalities is of course high when there is high maternal or paternal age, when the parents are carriers of chromosomal rearrangements, like I said, autosomal dominant, 50% recurrence, autosomal recessive, 25%, or if they have a history of aneuploidy or mosaic pattern in their own genetic buildup. It could be a previous child with a structural defect, and therefore the recurrence is about 2 to 3%. It could be an aneuploidy. Recurrence could range between 1.6 to 8% depending on what status the parents are. And the most common cause for a genetic evaluation, of course, will be a structural abnormality on ultrasound. So it's very, very important that when we start screening, we take a detailed medical history of both the parents. You could have a father with Holt-Oram syndrome or a Noonan syndrome, or they may show only mild features which you need to examine. And then, do they have a relevant family history? Very important is their history of consanguinity and a detailed pregnancy history of any exposure to some drugs like warfarin or anticonvulsive medication. Even advanced paternal age over the age of 45 of the father increases the risk of certain single gene disorders like achondroplasia, APERS, Crouzons, etc. So what are the screening tests in our changing era as we see today? We have, of course, shifted to first trimester screening as compared to second trimester screening to look for abnormalities. And first trimester ultrasound is the new pillar in obstetric care because there are tremendous advances in ultrasound and we have increased insights of embryonic development and, of course, the nuchal scan, which we are going to talk about. We must do both transabdominal and transvaginal imaging because there is superior resolution with transvaginal, as I'll show you. And of course, use color Doppler for the fetal heart, ductus venosus, and use 3D and multiplanar imaging as and when required. Now, we do have a lot of explosion of technology, as you can see, especially I use the GE equipment, and we have the 9L probe, the 612 probe, and the C29 probe, which are extremely useful for imaging in the first trimester. Now, this is just to show an example. This is a 10-week fetus, or 9 weeks, 6 days, and you can see that there is something wrong, but we're not very sure. On close inspection, transvaginal imaging, you see that the classical butterfly sign is missing, that as you can see here, the Fox cerebri is not complete, the choroid plexus are not seen separately, and this is the fusion of the thalamus here, and you see a monoventricular cavity at 9 weeks, which is a hollow prosencephalia. So this is today a 9 to 10 week diagnosis. Another fetus here, you can see at about 12 weeks, you can't see much because of the high BMI, but as you go into high resolution imaging, the same fetus you can see has pleural effusion, there's marked nuchal edema, there's A-wave reversal in the ductus venosus, and there's pericardial effusion, and this is a cardiac abnormality with reversal of flow in the pulmonary artery indicating a pulmonary atresia. So we must use color, transvaginal imaging, and all other tools to look for our abnormalities. Now, here I will switch to going on to a little video demonstration in the first trimester imaging, and we'll see how we do a standard nuchal scan. So as you can see, this is the fetus, which is here, and I have started with the ductus venosus here. We are generally opportunistic. We look at the position. We try and get a fetus in neutral view. In the long axis, the midline sagittal view is one of the most important views that we see, and then we focus on the head and neck and magnify the image. As you can see here, this is the nuchal here. The nuchal is the space, is the translucent space in the back of the subcutaneous tissues of the neck, and we measure on to on. And of course, I'll show you later, and that's the nasal bone that was seen here a few seconds back, and we'll show you more of that. And so we use multiplanar imaging. We go from sagittal to transverse to coronal, and you can see here now we are in an axial plane at the level of the lower extremities. That is the stomach shadow, the fluid in the stomach, so that's the abdomen. I'm sure radiologists are all used to these planes. The first trimester, usually we measure the CRL, but in special situations when we suspect an abnormality, we always do all the biometries. So the abdomen, the long bones, that's the heart, and we take the Doppler across the tricuspid valve, and you can see that the gate is a little bit wide. This is the inflow into the into the atrium, and that is the outflow in the pulmonary artery. Now this is the cranial shadow. You can see the classical butterfly. We magnify the image. That's the fox, and we look at the cranium. We take two views. So at each level, we'll take about two views, and that's the midbrain that was there. And then we go down. This is from the axial view, we go on to a coronal view. That's a premaxillary triangle, the nasal bone, the maxilla, and the floor of the palate. This is the mandibular gap here. And we'll move ahead a little bit. Its first trimester is a very good view to see the extremities, the movements, the three segments of the lower extremities, very well seen on in the first trimester. In fact, you can actually count the digits, as you can see here, the hands coming up there. So this is, there you can see the digits. You can actually count the digits to look for polydactyly. Now this is with transabdominal imaging, and all this improves, of course, when you go into transvaginal imaging, and we'll see a few clips of that. So very, very important that we get the full fetus stretched in neutral position in the midline, because these are day-to-day cases. These are not the best examples. I wanted to show first what we see on day-to-day basis. This is a normal woman with an average BMI of about 25, and then here we go into the axial view and look at the fetal heart with color. So that's the heart. It can be a little tricky. You go on to a cardiac preset, magnify, and you can see then that you will get some appearance of the four-chamber view. We use color very predominantly. You can see the two ventricles with the interventricular septum, and the fetus keeps moving. It's a small structure. You can see the two ventricles are symmetric in size, and that's the outflow tract. So the outflow tract joins the pulmonary artery and the aorta join together to form a V, and we'll see a little bit more of that. So that's the V that is formed by the ductus and the aortic isthmus, which joins together at that level. So at least these two views of the heart are very, very important to see the exact. That's the face a little bit. You can see the two orbits and the lens. Very important to identify the lens and the orbits, and that's the premaxillary triangle. You look at the spine and coronal, and as you can see here, the fetus keeps moving, so you have to keep moving along with the fetus. You take sagittal, coronal, axial sections, and you definitely follow a protocol. You have the ISWAG guidelines of first trimester imaging. Now this is the uterine artery as it emerges from the iliac arteries, and the first trimester we know is an excellent window for pre-eclampsia screening. So we identify and we look at the pulsatility index of both the sides, and then we take a mean of the pulsatility index. It's 1.48 here of both the sides. The 95th centile is usually less than 2.3. Of course, we have charts, and we look at the charts, but the mean PI, if you take both the sides, is about 2.3. Now that's the nasal bone that you can see here, separate from the skin. And this area here, the midline view of the fetal cranium, is very important for the nuchal, and also looking at the brainstem and the intracranial translucency. And of course, we'll see still images of that. Now, I'll go to the next clip here just to show. Again, this is a very high BMI individual. We look at the placenta, we look at the cervix, we come to the fetus, look at the gestational sac size, and you can appreciate that the visualization is a little less in this particular situation because of the high BMI of the individual. Of course, taking the CRL is the first step. Biometry is best judged by the CRL. In the first trimester, as you know, it's the most accurate. We look at the ductus with color, and what we do is, this is the initial sweep you will get. You try and localize very carefully on the ductus. That's the ductus. And then we take about 3 or 4 samples. There should not be more than 3 or 4 samples, and that is the A wave. This is the pulsatility index in the ductus. So I'm just showing you again, as I switch, this is the uterine artery, but I'm going to switch directly to transvaginal imaging. Now you can see in transvaginal, the visualization is much better than transabdominal. That's the aqueduct of Sylvius. And the distance from the posterior occipital bone is a sign for spina bifida. So if the aqueduct is shifted posteriorly, indicates higher risk of spina bifida. That means there's Chiari-2 malformation. So we take 3 sections at each level. These are the orbits. That's the lip here and the palate. So we take the butterfly, the aqueduct, come down to the orbits and lip, and then go into coronal view. That's the premaxillary triangle, nasal bone on the top, maxilla, palate, both the hands here, and then we will move down. That's the premaxillary triangle here again, and then that's the mandibular gap here on the coronal view. So each view has a specific advantage that you can see on each view. Now we will go down to the abdomen, to the chest, and here again, like I said earlier, we take 2 views. One is the outflow tract and the four-chamber view. So we look for symmetry in the four-chamber view, and then the outflow tract, which forms a V sign, that is the dot and dash, and we'll talk about that. So here again, we'll go down further. Now this is the coronal view to see the limbs. Very important to see all the limbs, all the three segments of the limbs, and that's the heart again. So as and when the fetus gives us the views, you take a wide gate, and that's the tricuspid regurgitation. You look for tricuspid regurgitation. So this is the reversal of flow in the pulmonary artery. This is the forward flow in the ventricle here. You can see that. And there is no reversal suggesting tricuspid regurgitation. Then you will go down. So here we have shown a little bit of 3D imaging, surface rendered. You can see the fetal ear, the limbs very well with 3D imaging. And this is also very useful for the patients to see the fetus as a whole. So if you have 3D imaging, it becomes very useful. Otherwise, it's not really necessary. Now, 3D is sometimes useful when you don't get a nuchal very easily. So you take a volume and then go to the C plane, which is the midline sagittal plane, and that can be used to obtain a nuchal, especially if the fetus is always in a vertical position or in the coronal view. So that's the nuchal area here. Not the classical nuchal, but sometimes in difficult situations we use 3D to get the view for the nuchal, especially when you have a very difficult, or you could make the mother walk and wait for some time, and that's the intracranial translucency here. You can see that's the choroid plexus in the fourth ventricle, and that's the midbrain. So this is, of course, a volume image, so it won't be as sharp as a regular image. That's the aqueduct of Sylvius here. And so that is the use of transvaginal and 3D to get the relevant views. Now this is the heart here, that's the V sign, and then we will go on to the next clip here. So this will be the last of the first trimester clips. As you can see, again, transabdominal imaging. I have selected all high BMI individuals. You magnify the image. Very, very important that you magnify the image, and then you focus down. First, we always like to take, after 12 weeks, the fetus is fortunately in a horizontal position. When it's a vertical position, it's very difficult. This is a flexed position of the fetus, and therefore we do not take measurements in this situation. This is the triangle of the umbilical vein and the umbilical artery. Very important to see this triangle intact. It rules out extrophy of the bladder or infra-umbilical ventral wall defects. And we'll speed this up now. We'll go. So that's the nuchal here. We have magnified the screen here and focused on the head, neck, and the thorax. That's the nasal bone. This is the palate here. And we'll talk a little bit about that later. And then we go on to getting the other views. But predominantly, you see that once we switch to transvaginal, your resolution improves remarkably, and maybe a good idea to do transvaginal in most of these individuals when you don't have a good transabdominal window. So you focus on the head and neck, and you can see that the nasal bone is not visualized here. So there is absence of the nasal bone, and that can be quite common in an Asian population. That's the nuchal fold here. But what's most important, you can see that the nasal bone is not ossified in this particular situation. And that again is the entire fetus. And that's the perfect view for the CRL. You can see that the fetus is neutral. There is no flexion. The chin is not touching the chest, and that's very, very important. If the chin is not touching the chest, that means we are in a good position to take the views there. And then, of course, we magnify, focus at each level. As I said earlier, we take multiple sections. And you can see again the nasal bone is missing here. The nuchal fold looks quite normal, and we can actually take a view there. The lowermost axial section is the cord insertion, where you see both the iliac arteries and the bladder. So we keep taking sections. Now that's the right subclavian artery here, and we'll talk about that. This is the superiormost section at the level of the clavicle, where you come up from the heart and you will see the right subclavian artery. So the situs is normal. As you can see, the heart is pointing to the left side, and we just saw the stomach here, which is on the left side. So that's again very, very important. Now, these are standard sections. We will be taking BPD because a smaller BPD indicates spina bifida and lower extremities, etc. We will measure. We look at the environment, look at the limbs, and that completes almost certainly our evaluation of the first trimester. So I will now, if at all any questions at any point of time, please let me know. If you want me to show you anything again, I'll always show that again. Now, let's look at genetic evaluation in the first trimester. So we all know that today we are in an era of numbers where we have to give a risk to the parent as to what is her risk of carrying a genetic abnormality. And how do we arrive at those numbers? So the first number that we see is always the maternal age. And this chart is very useful. Of course, you have computers, you have websites, on your phone or your computer. There's www.perinatology.com or even the fetalmedicinefoundation.org, and you look at the age 35 and at the gestation period, the risk at 12 weeks of having a Down's baby is 1:249, and that's why we take 1:250 as the cutoff for looking at Down syndrome. So this is called the a priori risk or the maternal age risk. This is the first risk number that we give to the parent when we are dealing with an abnormality. And then, as you see here, we do screening tests. So in 1970s, maternal age was the only screening test, and the detection rate of Down syndrome was 30%. In 1980s, we had quadruple markers, so the beta HCG, inhibin, estradiol, AFP, and the detection rate improved to about 70%. And today we are in the era also of NIPT, but most commonly used is the combined first trimester screening, which involves NT, beta HCG, and PAPE, and the detection rate is about 90%, which is acceptable detection rate. So we owe a lot of our first trimester scan to this gentleman, that is Kypros Nicolaides, and he inverted the pyramid of care. As you can see, the pyramid was first the second and third trimester scans were important, and we realized that the 12th week scan is now the most important scan because it tells you about biometry, aneuploidy screening, malformations, maternal complications, and also multiple pregnancies. These are, of course, the most classical picture you could have when you do the sagittal midline scan. And as I showed you, life is not always getting these pictures. You have to get pictures which are reasonably good, as I showed you the three cases. So what do we look for in the sagittal scan? We look for the NT. Of course, we measure the CRL. In the fetal head, we look for CNS abnormalities like anencephaly, holoprosencephaly. We look at the IT sign for spina bifida screening. We look at the face. We look at the abdominal wall, the urinary bladder, and the spine. So biometry, of course, as I said, the fetus should not be flexed. That's very, very important. As you can see here, the chin is touching the chest, and that's the clue for the fetus to be flexed there. So you have to have a midline neutral scan. The dating is always done in the first trimester scan from the CRL, and then after 14 weeks, of course, we also use the BPD, but we use the BPD in first trimester to screen for spina bifida. Now, when we have a CRL which doesn't match with our dates, what do we do? So if the woman has very, very normal cycles, and if the CRL is even more than plus 1 week, then we know we could be dealing with abnormality in the form of trisomy 18, 13, or triploidy. But it's very, very important that we rule out abnormalities. So if you see here, there's an anencephalic fetus, and always the fetus is going to be small. So the CRL is going to be very small. So the first diameter that we always look for is the CRL. Then we look for body proportions, and this can be a clue. As you can see, this is a one of the twin pregnancies. The upper one is the normal twin. The second twin has severe growth restriction. It is small in terms of length and also body proportions. Normally, the abdomen is almost similar or a little less than the head, but here it's very, very narrow. This was again a case of triploidy, but it could be a trisomy 18. So what are the technical aspects when we do the scan? We must always do it between 45 to 84 millimeters. That is between 11 plus 3 to 14 plus 1 weeks. You can use transabdominal, transvaginal, and any transducer which you like. The high resolution transducers are preferable. You magnify the screen as I showed you, focus on the head and thorax, identify the nasal bone in the mid-sagittal section, the palate. This is a hypoechoic area of the thalamus or the diencephalon, which tells you that you're in the midline, and then you will get the three lines, that is the midbrain, fourth ventricle, cisterna magna, and this lucent space here is the nuchal. So you take more than one measurement because the nuchal may at times vary in its dimension, and take a largest measurement, and you take the maximum measurement. So you put the caliper on the white line, and you should see that there is separation from the amnion. So the fetus sometimes lies on the amnion, and you may overestimate the measurement. So that is exactly the lucent area here, and this is of course the intracranial translucency. Now these are transvaginal images. You can see the nuchal, the nasal bone very well. You can see the spine. That's the palate, you can see. And you can also measure some facial angles. So this is the Fmf angle, the frontomaxillary facial angle. You drop a line from the palate to the edge of the maxilla and take it here. And we'll talk about that, because when the baby has Down syndrome, the maxilla is small, and therefore this angle gets wide. And this is really the perfect image that you can get here. You can see that that's the nasal bone, the palate is wide here, and that's the intracranial translucency, and this is the nuchal. So these are some of the transvaginal images that you get. You must see, as I told you, that there is good gap between the chin and the chest. The fetus should not be flexed, otherwise your nuchal will get compressed. If the fetus is hyperextended, the nuchal will get widened, as you can see here, and this is of course a good neutral position. That is the amniotic membrane and should not be mistaken as the nuchal. As you can see, sometimes the fetus will come and sit on the amniotic membrane and give you a wide appearance of the NT. So you must see that the fetus moves up. You may have the cord sometimes, and then you measure above or below the cord. Now, very, very important that you don't measure in the prone position. As you can see here, that's the NT. Same fetus in the supine position, you can see that the nuchal edema is almost 3.7 millimeter. So this is very, very important. And of course, you never measure the nuchal with the whole fetus. You have to have only the head, neck, and thorax in the field. Now, once you have a nuchal which is wide, as you can see here, and you can see even the nasal bone is missing, there is a gap in the palate here, called the maxillary gap sign, then we know that you have a high risk of chromosomal abnormality, trisomy 18, 21, Turner's, or some other chromosomal defect. So it's as the higher the nuchal, the higher the chance of a chromosomal defect. Now, this is a fetus in prone position. You can see the nasal bone was not ossified, and we were not getting good views. So we waited for a week, and in 1 week, you can see that there is marked nuchal edema. The palate is small. The facial angle is 96 degrees. It's very wide, and you don't see the nuchal. And of course, this was a 40-year-old lady with an age risk of 1:53. And very high beta HCG levels, 10 moms, and this was a trisomy 21. The heart was, of course, normal. Now, a nuchal scan is never complete without the biochemistry. So we know that we have serum-free beta HCG and PAPE. And PAPE, a low PAPE level, because this is a placental protein, it indicates the high risk of trisomy 21. So any MOM which is less than 0.5 or lower than 1 is normal. And if you have a high beta HCG, that suggests a high risk for trisomy 21. So if your MOM of the beta HCG is above 1, so you look at the combined test and look at the individual parameters, look at the NT, and then you add them together in an algorithm which is provided free by the Fetal Medicine Foundation. You can then get a detection rate of 90%, as you can see here, with a 5% false positive. That means 5% of your cases will falsely be positive and they will undergo invasive test and the results will be normal. Now that is an acceptable detection rate, 90% with a 5% false positive. Now, how are these formula calculated? You have the a priori risk, that is the background risk, age risk. Then you have likelihood ratio of each parameter like the nuchal, the nasal bone, etc. And you multiply all these parameters and you get a new risk. So if you have a background risk of say 1:200 of here, and your likelihood ratio of a particular soft marker is 0.5. So you multiply 0.5 by 200 and you will get 1:400 as your new risk. And if your likelihood ratio is 2, then you divide and you will get your likelihood ratio as 1:100. And this is the software which is present on the Fetal Medicine Foundation site. You just send 3 images of the NT and you will get the entire software free, where you put the fetal heart activity, heart rate, because as you know, in trisomy 18, you can have a slow heart rate. In trisomy 13, you can have a high heart rate. You put the CRL, put the nuchal, as you can see here, it's 3.4. You put whether you're Asian or, and the nasal bone details, the facial angle, if you have measured tricuspid Doppler, ductus, and you will see that the nuchal is high here, and this will also give you a risk estimation. Now, when we talk of cystic hygroma in the earliest part of our career, we have come to realize that it is having the same implications as nuchal. So we need not call this cystic hygroma. You can call it generalized hydrops, but the implication is the same. You measure the nuchal and it is suggesting that there is nuchal edema. And of course, if the hydrops is involving the entire fetus, there's a high chance of having a Turner syndrome. Now, how do we use this information? We will get a risk estimation from the algorithm. And if your risk is 1:100 or above, that suggests that this is a high risk. In this population, 85% of your Downs babies will be there. Then you offer them an invasive test in the form of a chorionic villus sampling. If your risk is 1:100 to 1:1000, this is an intermediate risk where 15% of Downs babies will be there. You use other modalities like nasal bone, ductus venosus, or even an NIPT in this range. And if your risk is less than 1:1000, you will have only 1% of Downs in this population, and then you do your second trimester screening. Now, especially for the intermediate risk, Kipros has given us a lot of new soft markers like the nasal bone, the tricuspid Doppler, ductus venosus, and this will increase our detection range from 90% to 96% by and also reduce the false positive from 5% to 2.5%. So it's very, very important that we do look at these markers, and we all do that commonly in our practice. So that is the thalamus, that's the palate. Now here you will see 3 lines. That's the tip of the skin of the nasal bone. That's the skin of the nasal bone. And the lowermost line is the nasal bone, which is the brightest. And of course, that's a wide nuchal here that you see. So it comes like an equal to sign. Important thing is you have to be perfectly getting the perfect view of the nuchal. There should be no bone here, that is the zygomatic process of the maxilla between the nasal bone and the palate. And this is a very, very important precondition. You should also angulate your probe in this direction, because if you come in this direction, the beam will be perpendicular and you may miss the presence of a nasal bone. You also have to not be rotated from the midline. It has to be a perfect neutral position. Like I said, if there is even a 10% rotation, you will see the zygoma. And if you rotate 15 degrees, the zygoma will be seen, but the nasal bone will disappear. And you will erroneously call it a missed nasal bone. So very, very important that you see that there is no bone here between the palate and the nasal. And that's the skin, that's skin tip, and you don't see the nasal bone here. Now, it improves your detection rate, as I said earlier, but it's also a difficult technique. And in 5% of normal Asian population, the nasal bone will not be ossified in isolation. And hence, you must remember that if it is an isolated finding, we don't bother about it. We look for other markers, and we essentially don't measure the nasal bone, but you could measure. There could be a lot of errors, but there are charts available, and it's not really in the protocol. The second important tool is the ductus venosus, and that's a normal waveform. You can see continuity in atrial systole and in diastole, and in atrial systole here there is the A wave, which is continuous. If you get reversal, that's a positive sign indicating that there is a chance of having Down syndrome, as I said earlier, 95%, or it could also indicate a cardiac abnormality. So putting all these two together, you can have a risk of a major cardiac defect increases when your NT is high and also your A wave is reversed. As you can see here, this is the high risk of having a cardiac defect. Same also with tricuspid. So the only difference is here you widen your gate, put it across the tricuspid valve, and this is the forward flow in the ventricle and the reverse flow is in the pulmonary artery. But if the reverse flow is very high velocity, more than 60 centimeters per second, almost reaching 1 meter per second, then you know this is a tricuspid regurgitation. And again, it's a major indication of both a chromosomal abnormality and also a cardiac abnormality. So how do we use this information? You have an intermediate risk group. If you have abnormal ductus venosus or tricuspid regurgitation, the risk automatically increases to about 1:100, and therefore we would do a chorionic villus sampling. Now, I spoke about facial angle. This is the palate here. That's the line. It normally decreases because the maxilla grows with gestation from 84 to 76 degrees. But in some situations, you can see here the maxilla is small and therefore the angle will be wide, and that is an indicator of Down syndrome. The other angle that you look for is the mandibulomaxillary facial angle. You drop a line from the mandible to the palate, and if this is narrow, it indicates that the mandible is small and suggesting that it is micrognathia, because micrognathia can be a very subjective diagnosis. So very important that we be objective, and you can see it decreases from 114 to 103 as time goes by. And this is obviously a small mandible here. The fetus also has a few bifid thumb, and there are dilated jugular sacs indicating that this is a chromosomal abnormalities. This is a pure Robbins sequence with a markedly small mandible in this fetus with bilateral cleft palate, as you can see, cleft lip, as you can see here, and also a cleft palate. Now, what is the importance of nuchal? Is it only for aneuploidy? No. The increase in nuchal can suggest that we could be dealing with a cardiac defect, a chromosomal defect. There could be spontaneous fetal death with no explainable cause. You could be dealing with genetic syndromes and major abnormalities like skeletal abnormalities, congenital diaphragmatic hernia, and some syndromes, as you can see here, the commonest being the Noonan syndrome. And there's a huge list of abnormalities that you can see. This is a congenital diaphragmatic hernia. This is a limb body wall complex, which can show normal chromosomes with an abnormal nuchal. So basically some phenomena which is causing lymphatic obstruction. And so I will just show you one case. This was a fetus with generalized hydrops. There's pleural effusion. The limbs are short. There's marked nuchal edema. And you can see that there is a single outflow tract. You don't see the V sign. And there is some calcification you see in the heart. So multiple abnormalities as early as 11 weeks. That's a normal fetus here. Now, when we did the evaluation of this fetus, so this is the protocol. We did a FISH, a karyotype, a microarray, and everything was normal. And then we finally did a clinical exam, and the final diagnosis was a hemolytic anemia, a glucose 6-phosphatase isomerase abnormality deficiency, which results in hemolytic anemia. Now, we could have never suspected it on imaging, but imaging guided us to do a genetic evaluation in the form of a microarray, a routine aneuploidy screening, and finally, on a clinical exam, we could get the final diagnosis. So what it means to show is that today, diagnosis is not limited alone to doing a evaluation for trisomy 21 alone. You could have other abnormalities. Now, this is another very, very common situation. 34-year-old female, gravida 1 with nuchal edema, and this nuchal edema persisted on to the second trimester. You can see 6.1. We did a FISH microarray, normal, karyotype normal. The infectious screen was normal, and finally we did a clinical exome. These are the third trimester images, and you can see very low set ears along the mandible here, horizontally placed. There's a upturned nostrils, very wide forehead, and the final diagnosis was, of course, a Noonan syndrome. So Noonan's usually leads to cardiac abnormalities in the third trimester, but here we were in the first trimester with nuchal edema, second trimester nuchal edema, not coming to a final diagnosis, and this was an abnormal variation in the PTPN11 gene, which is one of the genes responsible for Noonan syndrome. And you know that Noonan's is the male counterpart of a Turner syndrome. So very important that we have, when we have abnormality in the first trimester, we have a whole list of genetic tests which we can do to confirm the diagnosis. Now, this is not from my case series. This I picked up from Katia Bilardo's case series, where just with abnormal nuchal and a cardiac defect, when they did a whole exome sequencing, so going beyond a clinical exome, they did a whole exome, and the final diagnosis was a Carbo-Key syndrome. So very rare, but of course it shows the extent of diagnostic possibilities just beginning with a nuchal scan. So this is the importance of doing first trimester screening. Then what are the small other benefits? We can look for cleft lip palate, and as you can see, this seminal paper by Ravi Choi called the maxillary gap sign. That's the normal maxilla. When you see a lucency here, this suggests that this is high risk of having cleft palate, and that's called the maxillary gap sign. And it can be associated with other abnormalities, and therefore you will pick up 96% of cases of cleft lip palate. If it is isolated, you'll pick up 65%. And you can see here a fetus with absent nasal bone. There's a maxillary gap sign here, and you can see marked depression of the nasal bridge. There's hypotelorism seen on the frontal view. There's a cleft lip here. There's on the axial view, there's cleft palate. And on the cranial scan, you can see holoprosencephaly. So very, very clear that this is a first trimester diagnosis of trisomy 13. The fetus also had a Fallot's tetralogy and a syndactyly. Now, this is a very, very important sign when you see fusion in the first trimester. And you can see here again, the ear is also abnormal. And all started with just showing abnormal nuchal here you can see, and also facial features. So multiple abnormalities, and that suggests this trisomy 13. Now, the other important sign that we look for is the IT sign. Again, exemplified by Ravi Choi, that is the midbrain and the brainstem. This is the posterior margin of the brainstem is the first line. This is the fourth ventricle, choroid plexus, second line, and the occipital bone is the third line with the cisterna magna behind it. And this is cleft palate. I will skip this. This is, I think some slides have got mixed up. This is a coronal view of the, as I told you, the premaxillary triangle, the nasal bone, the maxilla, and the palate. and this is the mandible in the axial view. Very important, because if you see a fusion of the mandible, that's the mandibular gap sign, which is not seen, suggests that the mandible has fused posteriorly, because this is supposed to be the gap where the mandible goes ahead of this gap and fuses, indicating micrognathia. And it's also a good view to see hypoplastic nasal bone. And as you can see, that's the classical premaxillary triangle with the mandibular gap. And here there is a defect in the floor of the premaxillary triangle, indicating a cleft palate. So it's a very, very important view. Again, a defect in the palate with premaxillary protrusion, and you can see here that's with the bilateral defect in the palate, suggesting a bilateral cleft lip and palate. Now this is the loss of the mandibular gap, suggesting that there's micrognathia, and you can see on the sagittal view the mandibular bone is very, very small. Now here again, sorry, we come back to the IT scan. There was a mix-up there. You can see that we can see three pieces of information. That's the brainstem, that's the fourth ventricle, cisterna magna. When you have compression of the brainstem occipital diameter, that is below the fifth centile, indicates that the brainstem is herniating, and therefore it's a sign of Chiari 2 malformation. And at the same time, there is a normal ratio, the brainstem to brainstem occiput ratio, which is normally 1 or less, because these are equal spaces. But if the brainstem widens, that means the fourth ventricle is compressed and the cisterna magna is compressed, and this fetus has a spina bifida. So this is a classical example. You can see that there is typical widening of the brainstem. The fourth ventricle is markedly compressed, and so also this is the cisterna magna, and you can see there is a meningomyelocele at the lower end of this fetus. So that's very, very important. And the same thing can be seen on the axial view. So as I told you earlier, this is called the crash shine. So that's the aqueduct of Sylvius. When the aqueduct of Sylvius moves posteriorly, it indicates that there is a high chance of having a spina bifida. Some people have also described the corpus callosum, but I don't think this is a very, very well-defined sign. So we have something called as the midbrain Fox ratio. And normally it is about 0.5 to 6. That means this is half this diameter. But when the corpus callosum is agenetic, the midbrain herniates upwards, and that causes this ratio to increase, as you can see in this particular picture here. And this is an indirect indicator of agenesis of corpus callosum. Now, this is a first trimester fetus with nuchal edema. There's holoprosencephaly. But when you go to the sagittal view, you realize that that's the midbrain here. It has gone significantly higher, as you can see here, indicating agenesis. But we know that in holoprosencephaly, the corpus callosum is agenetic. And of course, this fetus also had polydactyly, and that's the dorsal sac. So multiple abnormalities indicating a trisomy 13. So this is as far as we go in aneuploidy screening. We have these ultrasound guidelines. I suggest that you go through these ultrasound guidelines and you look at these guidelines to understand everything about first trimester screening. So the other advantage of first trimester screening, of course, which we cannot talk about because of limitation of time, is the abnormality scan on first trimester screening. So we look for a whole range of abnormalities, but we'll keep that for another day. What's important is that we'll round off the first trimester screening with a little word on NIPT. And as I told you, 2012 was a major change in genetics, where we had microarray and we had NIPT coming in. With NIPT, we have a 99% detection of trisomy 21. But we must remember that there can be false positive cases especially in sex chromosome abnormalities. And NIPT is only a genotype test. It is not telling us about the phenotype of the fetus. It cannot tell you whether the fetus has an anencephaly or other structural abnormalities. Also, there could be false positives due to placental mosaicism, vanishing twin. If the mother has a mosaic chromosomal pattern, if there is a maternal malignancy, and there will be a failure rate because of low fetal fraction. So that what we call as a no-call rate. Now, this was a paper which a normal NIPT, and the outcome had various abnormalities like Potter syndrome, hydrocephalus. So very, very important that you do ultrasound before doing a DNA NIPT. So any fetus with a structural malformation, especially NT above the NI 99 centile, we don't do NIPT. We must do an invasive diagnosis straight up front. And when we talk of accuracy, which is near 100%, you must remember that in special situations like marked obesity, conception by IVF, twin pregnancies, there will be a failure rate with low fetal fraction, and therefore the actual accuracy will drop to about 80%, not 100% in these situations. And therefore, it's very, very important that you use this algorithm, that if you do first trimester screening, you start with combined test, and if you have a high risk, we offer invasive testing. The intermediate group, again, your cutoff depends on your local experience with invasive testing. We generally take about 1:100. The Fetal Medicine Foundation is suggesting 1:10. So if your intermediate risk is between 1:10 and 1:1000, then we offer cell-free DNA. If there is no result, we again rely on the combined test. If it is 1:100, we do invasive testing. If it is less than 1:100, we move on to second trimester screening. If it is screen positive, we again do an invasive test. If it is screen negative, we don't do anything. And of course, if the combined risk is less than 1:1000, we don't do anything. Now, the other advantage of doing first trimester screening is to screen for preeclampsia. So we measure the mean arterial pressure of both the arms, and in a sitting position without crossed legs, we do the uterine artery Doppler as I've shown you earlier. We take the mean uterine artery pulsatility depending on this chart here of both the sides, add it to the information that we get with biochemistry specific PLGF, and we go on to the Fetal Medicine Foundation site, and you will get a risk of preeclampsia on these, and that's very, very important. So you enter the weight of the mother, the mean arterial pressure, the uterine artery information, and also the inflammation of PLGF, that is, or if you have PAPE, if you don't have PLGF, you can use PAPE, and that will give us a screening detection of preeclampsia near 100% for preeclampsia before 32 weeks, 75% below 37 weeks, and less for preeclampsia above 33 weeks, 37 weeks. And you can see here a mother with bilateral high, very high resistance to flow in the uterine artery. And if you get a mother with high resistance and high risk for preeclampsia, we institute 150 milligrams aspirin from 14 weeks, 11 to 14 weeks to 13 weeks, taken only at night. And this will reduce the risk of preeclampsia by 50%. The other thing that we look for is, of course, a short cervix, more in the second trimester. But if the cervix is very short and there's marked funneling in the first trimester also, then we know that we are at high risk for abnormality. Now, what are the important structural abnormalities you must not miss? As I said earlier, anencephaly, holoprosencephaly, omphalocele, megacystis, hydrops, and gastroschisis. These are the abnormalities. Limitations are, of course, of size and the learning curve, and you need time to do a first trimester. So be good at the second trimester scan. You have to be rapid to adapt yourself to changing fetal position. Get the best out of your machine, examine systematically, and understand fetal development. Now, complete anatomical survey is possible in about 98%, and about in a low-risk possible situation, you can pick up about 80% abnormalities, especially the lethal abnormalities. So I will end my first talk here. Are we doing questions now? Dr. Rupa, Dr. Angle, are we doing?
Yeah. Hello, Dr. Lulla. I am Dr. Arnav Palwat. I am moderator here.
Okay.
Actually,
okay.
Thank you very much for the very illustrative and very informative lecture. We are getting some questions, but we thought we'll collect them and categorize them and have the discussion at the end.
Okay.
There's some questions. There are a couple of questions, but we'll collect them.
Okay, so should we move to second trimester
Yeah,
screening?
I think we'll move and we'll keep the questions to the end of the all lectures.
Okay. Very good. So, I'll just change my slides and we'll go to second trimester soft markers. So we can see when we move from first trimester to second trimester screening, in our context, especially in India, we do it between 16 and 20 weeks because we have a legal limit of abortion at 20 weeks. I'm not sure what is the legal limit in your country, but you could do your anomaly scan depending on your legal limit of abortion, and many countries prefer to do it at 22 to 24 weeks, specifically because you can see the fetal heart very well. The role for looking for soft markers in the second trimester has reduced considerably if you're doing first trimester screening, because as you know, as I spoke earlier, the detection rate is almost 90%. In the second trimester screening, your detection rate falls to about 80 to 90%. So it's not more than 90%. So you have four type of women coming to you: people who have had a high risk following first trimester, who did not opt for invasive testing and are waiting to look at second trimester results, and then those with a low risk of first trimester screening. We always do second trimester screening. Of course, multiple pregnancies where combined screening has a lower detection rate, and people who did not do their first trimester screening for whatever reason. Here we go on to doing the second trimester screening, and we look at a lot of parameters, and here again I will switch to the video here. So we will go to looking at the video. So of course, I'm not going to show you the best of the videos because you must see what is seen in day-to-day life. And we begin with whatever part is presenting. So here is the fetal head here. You can see that's the lateral ventricle, median margin of lateral ventricle, lateral margin of lateral ventricle. And we always measure behind the choroid plexus at the level of the parieto-occipital sulcus. So that's the near ventricle, the far ventricle. We measure the BPD at a slightly lower section, but you can also use this for the BPD. But more importantly, this is a section for the lateral ventricles here. You can see the choroid plexus in both the lateral ventricles here. And then we move a little lower down, that is the occipito-bregmatic view, where you see the thalamus like an arrow, and then you angulate your transducer a little posteriorly and you will see the figure of 8 of the cerebellum. Very important to measure the cerebellum at this type, and also the nuchal fold here behind the occipital bone. So here, of course, the upper limit is 6 millimeters. In the first trimester, the nuchal is usually less than 3 millimeters. The 95th to the 99th centile in the first trimester is 3.5 millimeters. So anything above 3.5 millimeter is definitely abnormal in the first trimester. Of course, we use the algorithm. Here, anything above 5.9 or 6 millimeter is abnormal. The other important thing we look for is the cavum septum. You can see here that's a pyramidal box here at this level, and that establishes the presence of the corpus callosum. And then you move to a coronal view to look at the lens, so that you have confirmed that there is no anophthalmia. You look at both the orbits, the premaxillary triangle again. This is the apex, the maxilla, and the palate. That's the upper lip and the lower lip here. And this coronal view is very, very important to look at the eyelids, to look at the lens and confirm that there is no anophthalmia. And then we move from there to the palate. So that's the floor of the palate here. This is, of course, that's the slightly angulated view of the palate, and we'll see some more pictures. And then you go on to the extremities. We look at all the extremities, of course, This is the cervix here. Don't forget that we must look at the placenta and the cervix. And the second trimester is a good window. Transvaginal scanning is, of course, preferred. And then you go sagittally, look at the spine. And you see the tapering of the spine at the lower end. And then, so we take axial sections, sagittal sections. We are coming down. We are looking at the tricuspid valve here for regurg, and you can see there is a little degree of physiological regurg we are seeing here, which is quite normal. We do see physiological regurg very commonly. And then we, of course, will look at the heart and rule out any cardiac abnormality in the heart. The situs is all right. That's the stomach on the left. The apex of the heart is pointing to the legs. You make the box of the color small, and that's the subclavian artery in front of the trachea. It's similar to a bicycle handle. And you can see both the internal mammary arteries, and that's the thymus here. It's called the thymic box. That's the trachea here. So we must see the subclavian artery going in front of the, you see the V of the pulmonary artery and the aorta, and that's the subclavian artery going like a bicycle handle there onto the right side. So that is the heart. You can see 4-chamber view. You narrow the box, because once you narrow the box, you will get a good frame rate. You will see echogenic cardiac foci here. So you narrow the box. This improves your frame rate. And we are in the cardiac preset. You can also use color to see symmetrical flow across the AV valves into the 4 chambers. And then you move slightly upwards. That's the pulmonary artery bifurcation. You can see the right pulmonary artery, left pulmonary artery. That's the aorta, superior vena cava, and the trachea out there. So that's an axial section, again 4-chamber view. And that's the V that is joining the pulmonary artery and aorta. So the 3-vessel trachea view. Pulmonary artery, aorta, superior vena cava, trachea here. And then we go into a 5-chamber view. And that will show you, this is the V again. That's the LVOT that you can see in a 5-chamber view. So very important to look for perimembranous septal defects. This is the interventricular septum here. And that again is the V. And so at least bare minimum in an anomaly scan, you must look for the outflow tracts, 4-chamber view, look for the color and look for the morphology. Of course, you can extend this to looking at the pulmonary veins, and we'll show that a little later, and the sagittal view of the heart. But let's move on, and we go down. Must confirm the presence of the diaphragm in the sagittal view below the heart. And this is the shoulder, humerus, the spine, the ribs. So that's the region of the diaphragm here. We look at sagittal, the hammock view for the IVC, and the superior vena cava here. And that's the arch of the aorta. Very, very important that you look for coarctation in this view. So sagittal view of the arches is very important to see for any narrowing. If at all one view, you must do the sagittal view. And always don't forget to look at the ductus. We've had situations where the ductus is absent. Now in the axial view, as you go down, you will take the abdomen and you will take the femur. So this is generally the standard protocol that I follow so that I don't miss anything. We have standard views. You can choose your own views. You can take abdomen and bladder. I take abdomen and femur. We finish with the head. And so all standard protocols so that you don't skip anything because you're used to your protocol. When you go down, both the iliac arteries, the bladder, and I usually take the kidneys along with it so that the KUB is finished. So that's both the kidneys here. You can see the renal arteries, that's both sides. And then you go for the extremities. So that's the femur. You look at the 3 segments, tibia, fibula, and sometimes they won't be outstretched like you see in the first trimester. So you've got to follow That's the crisscross legs. That's the foot here. Very important to see the angle of the foot with the tibia. You will see only one metatarsal in the sagittal view, suggesting that there is no talipus. And we always measure the foot and all the long bones. And of course, if you want, you can see the gender. Not recommended in our country. It's not allowed, but that's the humerus and the ulna. And that's the nasal bone in the sagittal view. But that we have already seen in the first trimester. Of course, if you have not seen, and don't forget to see the hands, because sometimes the hands can be missing, the feet can be missing, and that's the second hand. So very important that you document everything when you're doing a scan of the fetus. So, and then that finishes your whole abnormality scan. Then at the end, we look at the uterine artery again, and look for the high diastolic flow. The PI, 95th centile, at this stage, mean PI is about 1.5. So that's the uterine artery. Anything above 1.5 mean PI, that means the addition of both, and you have come at a mean of both the sides. You don't take individual uterine artery PI, you take the mean, and anything more than 1.5 is indicative of a abnormal high risk for uterine artery Doppler. Now, this is how you measure the lateral ventricles, as I told you, from outer to outer and at the parieto-occipital sulcus level. No other way of measuring that's the cerebellum. I'm just going to skip through a few reminders. That's the view of the cavum septum. You take a long axis, short axis, and it's usually 2. If it is widened in the short axis, suggests that partial agenesis or agenesis of the corpus callosum. And this is the orbits. Again, don't forget, look at the orbits, the premaxillary triangle. And then you move to the rest of the fetus. That's the heart. You look at the tricuspid Doppler. Look at the cord, iliac arteries, and kidneys. So you take axial section, sagittal section, coronal views, all the views that the fetus presents. You follow the guidelines and come to final views. That's, of course, the heart. I'm going to show you the heart a little better with a proper echocardiography. So that's the 4 views of the heart I already showed you, RVOT, LVOT. And so that covers almost everything. And, of course, the placenta and the cervix at the end. This is 21 weeks. And you can see that the visualization is much better here. You can see the 4 chambers. There's an echogenic cardiac focus here. And here we'll do an elaborated cardiac study. And so here you can see the pulmonary veins. When you drop this is the thymic box, that is the internal mammary artery, and you can see the thymus. When it is missing, you know you're dealing with 22q11 microdeletion. So that's the thymic box, and that's the subclavian artery. So that is something. Hello. This is. Then we move on to 27 weeks. That is the. So I think I'll just go back a little bit to show you the pulmonary veins. This is the pulmonary vein here. Both the pulmonary veins here. That's the left atrium, the aorta. So the chamber here is the left atrium. You can see the pulmonary veins very well. This is the offset of the AV valve. So tricuspid valve is always closer to the apex as compared to the pulmonary mitral valve. You can see here. And that's the papillary muscle which goes and attaches to the moderator band here. So you know you're dealing with the right ventricle on the right side. And that's the flap of the foramen ovale, septum primum, interventricular septum. And so we'll skip this. These are the outflow tracts, pulmonary artery, aorta, superior vena cava, 3-vessel trachea view. You can use color as and when you like. That's the pulmonary artery. This is the 5-chamber view with the LVOT, so for perimembranous septum here. That you take a Doppler across the semilunar valve. If it's more than 1 meter per second, you know you're dealing with stenosis. And this is actually doing the entire fetal echocardiography as I'm showing it to you now. You document 4-chamber outflow tracts, Doppler, look at the pulmonary veins, and look at the flow across the foramen ovale, look at the interventricular septum. And I will skip some of these. You can even do cross-sectional views, but not really important. And this is a sagittal view, like I said, very important. IVC, superior vena cava, the hammock view. You can see the diaphragm very well here. And that's the ductal arch, which is closer to the sternum. And from here arising is the aortic arch in the middle. So that's the hockey stick, and that's the candy stick. And you can see that there is no narrowing in the arch, suggesting coarctation. So I will stop here, and a few words on the text. I hope we are doing well for time. If there's any way you want me to speed up, please let me know. So here, okay. So this is all the views that I showed you. This is how we give our representation on the film. So we go from head, 2 views, sagittal view, orbits, stomach, femur, heart, 4 chambers, outflow tracts, cord, iliac, kidneys, sagittal of the spine, hands, and legs. And then, of course, we take specialized views. This is the palate here. You can see this is the sagittal view with the palate. The soft palate, you will see it in a minute here. That's the hard palate. This is the soft palate above the tongue. That's the head, of course, the circular villus, if you want to show. This is the stomach on the left upper quadrant, the heart on the left side. And if you have 3D, of course, spine, very, very important to do the sagittal view, because you can see the termination of the cord at L2, L3. This is a very important view to document. And don't forget to document the hands. 3D is, of course, a luxury and useful at times. But most important also is all the extremities. So the tibia, fibula, humerus, femur, ulna, the foot in 2D and 3D. In 3D, you can see the whole section in a smaller fetus. And that concludes the complete analysis. And then we look for soft markers. So we do the genetic ultrasound, and we know that we have screening tests and diagnostic tests. Biochemical methods, of course, once you have done first trimester screening with dual marker, we don't need to do the quadruple marker. It's only 80% accurate. So we rely more on abnormalities and all this list of abnormalities. In isolation, they have a lower risk. Of course, if there are multiple abnormalities, there's a higher risk. So these are called soft markers, because they are not abnormalities on their own, but they give you a risk of aneuploidy. So it increases the risk of aneuploidy, the individual markers, and each one of them has a likelihood ratio. So like I said earlier, we take the a priori risk. A priori risk is the first trimester combined risk. It may be something like 1:600, and then we look for soft markers and multiply each soft marker, and we will get a final risk. This was an old method of doing soft marker screening, the Benacerraf method. If you look for soft markers, you give them a score of 2, like nuchal fold, etc. We don't no longer use this method. So this was an old method. What we use now is the calculator-based method. So here we see that there is echogenic cardiac focus, pileectasis of more than 4 millimeter, short femur, short humerus. The likelihood ratio is 1 of each. So if you've got a background risk of 1:600 of a 28-year-old, these individual markers, because the likelihood ratio is 1, it will not alter the risk. So it will remain as 1:600. Now, echogenic bowel, if your bowel is brighter than the bone, has a risk of 1.65. So you divide 600 by 1.65, and your new risk is 1:363. So almost half your risk has increased. And then the important markers are, of course, nuchal fold, absence of nasal bone, ventriculomegaly, and the right subclavian artery. Now that's the trachea. If your subclavian artery is going behind, it will appear straight, not like a typical bicycle handle. And if any of these markers is there, each of them have a likelihood ratio of about 4. So you divide 600 by 4, and your risk increases to 1:50. But this is easily said, because if you have multiple markers, each of them will get multiplied, and you have this calculator available on the 2013 edition of the Ultrasound OBGYN. It's the meta-analysis of second trimester screening by Kypros Nicolaides. And you download this. It's a free download. It's an Excel sheet. You go on ticking whichever, for example, here you've got hydronephrosis present, short femur present, and your risk likelihood ratio of both these markers put together is 5.0. So 600 divided by 5 becomes something like 100, 120. And so your risk increases. Very, very useful for estimating the risk. And again, the same algorithm, 1:100 and above. In our case, we take 1:250 and above. We do amniocentesis, and the incidence of down is more than 90%. 1:250 to 1:1000 is the intermediate risk. Here we do quadruple marker for further testing. And if it's negative, no testing. If it's positive, we will do invasive testing. And of course, if it's low risk, we don't do anything. Now, very important that you do your soft markers very carefully. So you take the kidneys in the axial view, and if it's more than 4 millimeters, it is positive. The echogenic cardiac focus should be on the papillary muscle. It should not be on the wall. And therefore, it is best visualized here on the 4-chamber view. You can see it's not on the wall, it's on the papillary muscle and the chordae tendineae. Of course, short femur and short humerus are both indicators of Downs. And then echogenic bowel again is very, very important. There could be false positives, especially if there's been a bleed. It should be brighter than the bone, so you lower down the power or your gain, power of your gain. And yet, if you're seeing the bright bowel, then this is considered as echogenic bowel. And it could be due to IUGR, it could be chromosomal abnormalities, infections, and of course, cystic fibrosis. This is by far the most important marker, the nuchal fold. And if it is more than 5 millimeters, 16 to 18 weeks, more than 6 millimeters, above 18 weeks, then indicates either a chromosomal abnormality, again, like the first trimester cardiac abnormality, or a single gene abnormality. And here you can see that the nuchal fold is increased. There are also choroid plexus cysts and trisomy 18. ARSA is a very, very important new marker, and you can see here that this is a bicycle handle type of situation. You will essentially see it where you see the clavicle. If you see ARSA, that is aberrant right subclavian artery, it will go behind the trachea, and that will be seen below the clavicle. So here, this is a case of ARSA. That's the subclavian artery. It has a straight course. That's the trachea in front. This is the V of the outflow tracts, and you're going down below the clavicle, and you will see no clavicle there, and that's where you will see the ARSA. So that is an indicator of Down syndrome. And of course, ventriculomegaly, if it is measuring more than 9.9 or 10 millimeter, indicates a 3.81 likelihood ratio of having a chromosomal abnormalities. And it could be mild or severe, and there could be various causes, but we won't go to in that. And these are the various causes of ventriculomegaly. There could be midline septo-optic dysplasia, agenesis of corpus callosum. There could be calcification, infection, echogenic margin suggesting hemorrhage, or unilateral ventriculomegaly. Everything is the same. The implication is that it should be more than 10 millimeters. Now, this I already spoke to you about. There is absence of nasal bone here, so that is also included. The one good way of looking at the nasal bone length is that if your nasal bone BPD divided by nasal bone is less than 10, then that suggests a hypoplastic nasal bone. As you can see here, very small nasal bone. Again, here you see no nasal bone, and there's a depressed nasal bridge, and this suggests that this could be Down syndrome. This is a twin pregnancy with one good nasal bone, one hypoplastic. And you can see it in the coronal view also in the PMT. There is no, the apex is not closed. As you can see here, the apex is closed. And of course, if you see multiple structural markers, like here you have an AVSD with a duodenal atresia, absent nasal bone, nuchal edema, you know that this is Down syndrome. And and these are other such cases. So I'll stop here. I think if there is any relevant question, we could consider that. Otherwise, we'll move on to the next talk. And I'll just show you three cases here. This is, of course, choroid plexus cyst. It's not important in isolation. So in isolation, if you see choroid plexus cyst, this is not a marker for aneuploidy, unless, of course, if you are seeing some other malformation alongside it. So you see large choroid plexus cyst, which is causing ventriculomegaly, and there is telepus. And of course, if there is overriding of the fingers, that's a normal hand. This is telepus, this overriding, and these three are indicative of trisomy 18. Of course, there will be other markers in trisomy 18. You will get short limbs, strawberry-shaped head, and you will see cardiac defects with overriding of the hand, and you're not seeing the stomach here. So you'll see multiple combinations of other features with these conditions. Now, this is the fetus with polydactyly, increased prenasal soft tissue. There's a cleft lip and palate, as you can see here, and polydactyly here, again suggesting trisomy 13. So these are the three common abnormalities, and by far the most common abnormality that you will see in the first second trimester is a generalized hydrops, and this is indicative of a Turner's syndrome. And you go on to a cardiac evaluation, you will see generalized hydrops. The left ventricle will be small. On the three-vessel trachea view, the aorta is small. You may see an omphalocele at times, and this is indicative of Turner syndrome. So coarctation, this is 12 weeks. Coarctation with generalized hydrops is an indicator of Turner syndrome. So I will stop the soft markers here. If there's any question at this time, how are we doing for time, please? Hello? Can you hear me? Hello?
Yes, we are able to hear you.
So are we doing questions now, or should we move to our third talk?
No, we move on and we'll keep the questions to the last.
Okay,
we are collecting
okay.
questions.
Okay, so we have two more talks. One is multiple pregnancies, and one is interventions. Now, before I go on to multiple pregnancies, I'll take a few brief minutes, because I thought I will take a break for questions, but if you're not taking questions, I must tell you that when we're doing genetic evaluation of the fetus, it's not only always about Down syndrome. And today we know, because as I said earlier, we have microarray and we have clinical exome. We can see that 1% of all babies will have neurological handicap, and these could be due to more than 100 genetic syndromes, and microarray can find 40% of them. Then 1% of all babies develop autism, and again microarray can find the cause in about 20%. And so we have new diagnostic tests, and this has been helped by the fact that today we know that the risk of amniocentesis is as low as 0.8%. It is as low as 0.1%, and the risk of CVS is as low as 0.2%. That means 1 out of 1,000 and 1 out of 500. In the earlier days, we used to think the risk of CVS is 2% and the risk of amniocentesis is 1%. But we all know now, after this paper published by our very own Ranjit Akolekar in the year 2015, that we never looked at the background risk. That is, if at all we did not do a CVS or an amniocentesis in these babies, some of them would anyway die even if without doing a procedure. So they actually analyzed the background risk, minused it from the risk of amniocentesis, and this is the final risk which we are dealing with today. So the risk of an invasive procedure. So what we really call as an invasive procedure is hardly invasive. So if you see a risk of CVS, it's only 1 out of 500. The risk of amniocentesis is 1 out of 1,000. And this brings us to the fact that we have many other markers other than soft markers which can lead us to a diagnosis of genetic syndromes and structural malformations like deletions and duplication. Specifically, even if you see IUGR, if you have IUGR in the second trimester, which can be symmetrical or asymmetrical, then 20% of them could be due to chromosomal abnormalities. So the moment you have IUGR with, say, something like polyhydramnios, or if there is a structural malformation along with IUGR, you could be dealing with a chromosomal abnormality. So triploides is very common before 26 weeks. Trisomy 18 is very common after 26 weeks. And there's a whole list which is ever ending. In fact, we just did a clinical exam of one baby the other day, and we found a rare syndrome, a 3M syndrome. So these are ever increasing list of abnormalities that we find with chromosome with IUGR. And then if you see any structural abnormality, for example, cardiac, facial, CNS, or multiple abnormalities, even if you have a normal chromosome or a karyotype, and if you do a microarray, 9% of fetuses with multiple abnormalities will have a deletion or a duplication. Individually, each abnormality will have about 4 to 5%. So today it's a standard of care to do a microarray instead of just doing a karyotype. So you do a FISH, a karyotype, and then move to a microarray. Now, if you see this paper, if you see nuchal edema, and if you've got a nuchal edema more than 4.5, then our standard protocol today is to do a FISH or a QF-PCR and follow it up with a microarray, because a microarray can add 26.5% detection of other abnormalities which would be missed on a karyotype. So the message there is that if you have a QF-PCR which shows Down syndrome, then you move to karyotype, because karyotype will tell us which type of Down syndrome it is. I told you earlier there are 3 types. And if it's a translocation type of Downs, then you do the parental karyotype to know whether the recurrence risk is high or low. But if the QF-PCR or the FISH does not show an aneuploidy, that means it is normal for 13, 18, 21, and 6 chromosome, then you don't do a karyotype. You straight away go to a microarray. And you can see here that if you have a posterior fossa abnormality like a Dandy Walker, 15% chance of picking up a structural malformation in the genes, either a deletion or a duplication, if you do a microarray. Holoprosencephaly 10%, other CNS abnormalities about 4 to 8%. And there's a whole list of abnormalities on ultrasound that will guide us to which abnormality you're dealing with. For example, if you've got a rhabdomyoma in the heart, you know you're dealing with tuberous sclerosis. If you've got an absent thymus, I showed you the thymic box, then you are dealing with a 22q11 microdeletion, and that is called the catch-22 or the D. George's syndrome. So I will just show you one case here. This is the fetus with cleft lip, bilateral cleft lip, and there is an abnormality in the heart. There is a Fallot's tetralogy. So this is a dilated aorta which is got an I sign. It is moving in this direction, and that's a small pulmonary artery here, indicative of, you can see the difference between the aorta and the pulmonary artery, and the thymus is missing here. You don't see the thymus. This is suggesting 22q11 microdeletion. Another fetus with a dilated pulmonary artery with bidirectional flow, indicating absent pulmonary valve syndrome. So that is a normal fetus here, showing you the 3-vessel trachea view, and that's the thymus. Here you can see that there is no thymus. So this is another fetus with the Fallot's, but you can see the thymus. That black shadow here is the thymus. That's the lung. So this suggests that this particular fetus with Fallot's has no 22q11, or a risk is lower. But here the vessels are actually touching the chest and there is no thymus, and this was a case of 22q11 microdeletion. And going on, so on and so forth. This is a fetus with a thickened aortic valve. That's the right ventricular outflow. You can see right pulmonary artery. This is the aortic valve which is thickened, and there is on a sagittal 5-chamber view, you can see that the aortic valve is thickened and there is turbulence here. This was a Williams syndrome. If you have agenesis of the corpus callosum, as you can see here, there's no corpus callosum on the sagittal view. You could be dealing with, this is the second most common deletion syndrome, is 1p36, and you could have a cardiac and other abnormalities. And this is the same fetus. There's also a widened cisterna magna. The cerebellum vermis is rotated, suggesting that this is a Blake pouch cyst. The corpus callosum is partially seen, not seen fully, indicating a microdeletion. You can see the frontal horns are separated, and this was a malformation on microarray, which goes into these numbers. You cannot even talk about them. So there is a gain of so many kb on the chromosome, so in chromosome 11 involving 542 probes. So what I'm trying to show here is that the moment you find a structural defect on a microarray or on an ultrasound, you immediately move on to doing a microarray. Now, you will see single gene disorders, like if you have hydrocephalus here with dilatation of the third ventricle and the aqueduct is not dilated, you immediately look at the hand. So I'm just showing you how ultrasound can pick up some markers which tell us that there could be a single gene defect. The moment you have an adducted thumb, you know you're dealing with something called as the L1 syndrome or the X-linked aqueductal stenosis. So you have a female carrier and a male is the sufferer. So as I told you earlier, the X-linked syndrome, it has various names. It's got the L1 CAM, but predominantly you have aqueduct stenosis and you have abduction. Now, you can have autosomal recessive inheritance. Both the parents are carriers of a gene. This can happen specifically if there's a consanguineous marriage, if there are some families which are carriers of particular abnormalities, and the most common being the ciliopathies. It's called the ciliopathies seen in consanguineous marriages, and common syndromes being the Joubert syndrome and the Walker-Warburg syndrome. Now, these ciliopathies have a mix of abnormalities. So they have renal abnormalities, CNS abnormalities, skeletal abnormalities, and limb abnormalities. So you have various types. Why I'm talking about all this is the phenotype is very, very important. You see a phenotype abnormality, like this is the molar tooth sign of the midbrain on the axial view of the brain. And we can do a CNS webinar sometime and we can talk about. But here, what we are talking about, the fact is that both the parents are carrier for this Joubert syndrome. And when we see the fetus, we look for the phenotype. This is a typical midbrain appearance. There is cerebellar hypoplasia. The midbrain looks like a molar tooth. And the fetus, when we do an amniocentesis, is confirmed homozygous. So you can see here, present homozygous in the gene name is INSP5E, and this is typical of Joubert syndrome. So that's the Jouberts. You can see cerebellar hypoplasia, cisterna magna dilatation. This is the midbrain, which appears like a molar tooth that we see, and that is typical of midbrain. This is first trimester hydrocephalus, because normally we don't see hydrocephalus in the first trimester. And if you go on to a sagittal section, you can see that the midbrain is kinked. Now, I'm not trying to do a neurology course, but I'm just trying to show you the power of ultrasound today. This is hydrocephalus because the fox is seen. That's the third ventricle which is dilated. The cerebellum is hypoplastic. The midbrain is kinked, and we know from our MRI information in the pediatrics that this is typical of Walker-Warburg syndrome, the kinking of the midbrain and widening of the fourth ventricle here. Now, these are all ciliopathies. The moment you have enlarged cystic kidneys or bright kidneys, we look for a whole host of syndromes. And if you have polydactyly, this is typical, as I told you earlier, of a ciliopathy, which is the Bardet-Bardell syndrome. And one of them is also the Meckel-Guber syndrome. So syndromic analysis is possible. That is polydactyly. You have a non-occipital encephalocele, cystic kidneys. So we must look, when you find an abnormality, you look for other abnormalities. Now, even if you have urinary tract dilatation, which is recurrent in a family with multiple family members having a problem, then we could be dealing with a genetic abnormality, which is called the Kakut abnormality. So, congenital anomalies of the kidney, urinary tract, and the genes identified for these are here listed here. So, all these genes are highlighted. Now, if you have hydrops, initially, we used to consider infection, cardiac, and other causes to be very high on the list. But with the advent of microarray and clinical exome, you can see here today the number one cause of non-immune hydrops is today a chromosomal abnormality. So I'm just going to show you a very, very rare case. This is a fetus who came with the second child with hydrops. The first child was not evaluated. You can see there is lower limb abnormalities also. There's ascites, pleural effusion. There is absence of flow in the umbilical artery, IUGR, mild ventriculomegaly. But most importantly, what we were seeing here was basal ganglia calcification, if you see on the axial view. The moment we see calcification in the brain, we know we are dealing with an infection. So we did MCA, Doppler was normal, torch was positive, but the avidity test was high. So IgG was positive. We don't rely on the IgM. If the avidity is high, suggests that this is an old infection, not a recent infection. We did FISH was normal, microarray was normal. Then we did amniotic fluid analysis, and the torch was negative. That means the fetus was not infected. The platelet count was low, and this was an indicator. Then we did a clinical exome of both the parents. It's called a trio exome, and we chanced upon this abnormality in the TREX1 gene, and this is called as the pseudo-torch syndrome. So manifestations are like torch, but this is not an infectious torch. So this is a genetic abnormality called as Aicardi-Gautier syndrome, which is inherited because both these parents are carrier. This is an autosomal recessive condition, and you can see that the fetus is affected, and this is called as a pseudotorch. So the intention of showing you that is that the importance of knowing genetics and doing the complete evaluation from FISH, karyotyping, torch to a clinical exome gives us the answer. Now, there are some autosomal dominant conditions like holoprosencephaly, tuberous sclerosis, where one of the parents is affected and it gets transmitted 50%. So, of course, holoprosencephaly is associated with multiple other abnormalities. I won't go through the details. This is one type of holoprosencephaly where you ask the parent to smile, and you will see that there is a solitary median incisor bone. Normally we have two incisor bones seen on axial ultrasound, but when the father smiles and you've got a single incisor and you've got holoprosencephaly, you know you're dealing with an autosomal dominant condition. So again here another this is the same fetus with Noonan syndrome I showed you earlier, which can also be an autosomal recessive. So USG has certain lead points which you should look for. Look for limb extremities. You have hallux valgus, talipes, polydactyly, rocker bottom foot. These are all signs. The hands, you have the lobster hand abnormality, the overlapping of the fingers, missing small phalanx in trisomy 21. Polydactyly, very, very important for ciliopathies, as I told you earlier, Meckel-Gruber, short rib polydactyly, all other ciliopathies, and of course, syndactyly is also very common indicator of a malformation. So I showed you this fetus earlier. Now, when you have growth restriction with upper limb abnormalities, you could be dealing with some syndromes. Here, of course, this is the Cornelia de Lange syndrome. So cardiac and hand abnormalities, the radial clubbing of the hand, as you can see here, due to missing the radius here. And you can see multiple abnormalities. You have micrognathia, renal abnormalities, single umbilical artery, pre-auricular tag. And so the moment you find an abnormality, you go into screening and you find that there could be other abnormalities, facial abnormalities. There's depressed nasal bridge, which is the Binder's facies. You have prominent forehead, as you see in achondroplasia, micrognathia, cleft lip palate, and all these are indicative of various syndromes and chromosomal abnormalities. So these are USG lead points. You can have a small ear, folded ear. As you can see, this is the postnatal picture of this. You can have a very small ear on 3D imaging, or low set ears, as you saw in this case of Noonan's syndrome. This could be trisomy 13, 18, 21. You can have a pre-auricular tag. Of course, you will need 3D imaging, and this could be an indicator of various syndromes. So again, the idea of showing this today is that ultrasound is a key finder for various genetic abnormalities. All skeletal dysplasias can now be diagnosed in the first trimester before you have limb abnormalities, just on the basis of genetics. So you know that the FGFR3 is responsible for thanatophoric dwarfism. You have the COL1 gene responsible for osteogenesis imperfecta. The chondrodysplasia punctata is an X-linked dominant abnormality. And you have the SOX9 gene in campomelic dysplasia. Of course, there has to be a family history, or sometimes these may present in the first trimester with an abnormality. This is, of course, just Apert syndrome, craniosynostosis with typical mitten hands that you see here. So what I'm trying to show is that ultrasound today is a very powerful marker for looking at key lead points for which you can then come to a final diagnosis. Even CNS abnormalities, even spina bifida, if it is recurring in the family, we know that this could be an abnormality. Cardiac abnormalities, the Fallot's tetralogy, hypoplastic left heart, AVSD, these can all be due to 22q11, as I told you earlier. The tuberosclerosis is presented as the rhabdomyoma. This is common as the TSC gene is responsible for it, and you can see small tubers in the brain here. And we do a genetic analysis of both the parents, and this could be, you could have an omphalocele, tracheoesophageal fistula, a duodenal atresia, or a congenital diaphragmatic hernia. And these are all pointers that you should do a genetic evaluation. And this is the flow chart that we usually use for doing a genetic evaluation. Suspected anomaly, go into the family history, look for consanguinity. We do serial ultrasound, do genetic counseling, and then we do testing. We do rapid tests, the FISH and the QFPCR. If we find any aneuploidy, we will immediately switch to a karyotype to know if there is a parental association or parental inheritance. If the QFPCR and FISH does not indicate 13, 18, 21 triploidy or monosomy, we will straight away go for a microarray, and if necessary, a targeted exome sequencing, as I showed you earlier in Noonan's and other cases. And these are the tests that we offer. If you have a high risk for aneuploidy on first or second trimester screening, we do CVS, amnio, FISH, QFPCR, KT, karyotyping. If there's a specific gene disorder, for example, if you have echogenic kidneys and you have polydactyly, we will go straight for the microarray. If you have structural malformation on ultrasound, multiple structural malformation, we would go for microarray and a clinical exome. Which, if you have a structural malformation which is specific for Downs, for example, duodenal atresia with AVSD, we will go for karyotyping to know which type of Down syndrome is it. Is it a translocation? And if you have NIPT, which is showing high risk, we never do CVS. We will always do an amniocentesis. Go for KFISH, QFPCR, and karyotyping, because in CVS we may get a mosaic pattern and then we may have to do amnio again. So in conclusion, today genetics has evolved a lot. We have all pregnant women should be offered testing. Specifically, ultrasound becomes very, very important. The combined screening is the best screening option. In the intermediate risk group, we may offer NIPT or other tests. USG is always important prior to NIPT. We have definite place for second trimester soft markers. We integrate all the soft markers, do a risk assessment, and then do invasive testing. And of course, if your maternal risk is high, but you have no soft markers, then this will reduce the risk of having an aneuploidy. The best genetic test, of course, is the earliest test is CVS. If you have a mosaic pattern, unfortunately, I will talk about that in the last talk, then we will do an amniocentesis. We will do a FISH QFPCR, and of course, we will look for maternal cell contamination in these tests before we do further testing. If you have structural abnormalities, microarray will add 6 to 13% over karyotype, so we prefer microarray. And unless you have a specific indicator on ultrasound for any of the aneuploidy, the loss rate of an invasive test is very low today, 0.1 to 0.3. So some people even suggest to offer it to all. Of course, we shouldn't do that, but that is the way it is heading. If you're very good at invasive tests, then a lot of information, specifically if there is an ultrasound marker, and we have a whole list of tests available today, the NGS, whole exome sequencing. And if yet we don't come to an answer, we store the DNA and come to a final diagnosis data. So I will, okay. So the next talk that we are doing is role of ultrasound in multiple pregnancies. And finally, the fourth talk will be fetal interventions, because a lot of fetal interventions will be done on multiple pregnancies. So I thought I'll do multiple pregnancies before I start with fetal interventions. Now, as you know, because of the increasing advent of artificial reproductive technologies and controlled hyperstimulation, our multiple pregnancy rate has gone up, and even twins is as high as 1.8 to 2.8%. Triplets is about 5.9% increased, 5.9 times. And when we're dealing with multiple pregnancies, 1% of all pregnancies are multiple pregnancies. Of course, these can depend on your reference center. If you're dealing with IVF centers like we are doing, we do deal with a larger percentage of multiple pregnancies. Almost 2/3 to 3/4 are dizygotic, thankfully, and 1/3 are monozygotic. So all monochorionic twins are monozygotic, but 6 of 7 dichorionic twins are dizygotic. That means 1 out of every 7 dichorionic twin is actually a monozygotic twin which has split early, and this is very, very important, and we'll talk about that. So depending on when the cleavage of the morula happens, if it is a very early cleavage, you can get a dichorionic diamniotic pregnancy between 1 and 3 days. If the cleavage is between 4 to 8 days, you will get a monochorionic diamniotic pregnancy. And if the cleavage is later, between 8 and 13 days, you will get a momo pregnancy, or monochorionic monoamniotic. And of course, if it's a very, very late cleavage, when the embryonic disc is already formed, between 13 and 15 days, you unfortunately land up with the conjoined twin. So now, when we talk of multiple pregnancies, we always need to know the zygosity, although it's not always apparent. But just to give a background, a polyzygotic multiple pregnancy is fertilization of more than one oocyte, and therefore these are fraternal twins or non-identical twins, as compared to a monozygotic mass which splits, and then you can get either a dichorionic diamniotic if the splittage is very, very early, or essentially a monochorionic pregnancy. So monochorionic diamniotic, monochorionic monoamniotic, fetus in feto conjoint, etc. Now, zygosity is not very important. The chorionicity is important, because we need to know whether they are in separate chorionic sacs for further management and for the complications which are higher in monochorionic pregnancies. But what's important, as I told you earlier, a dichorionic twin is most of the times dizygotic, but sometimes it can be monozygotic. That means a very early splittage. So they usually will have the independent placentas, isolated systems, and the only complication usually you deal with is either a congenital abnormality or growth restriction. In a monochorionic pregnancy, on the other extreme, there is a sharing of the placenta, and therefore we deal with either malformations, TTTS, as you know, TAPS, and selective IUGR. And the complication rate, neurological and otherwise, is higher with a monochorionic pregnancy. Now, if you have a dichorionic pregnancy and it can be yet monozygotic, what does it mean? So if you have an abnormality in one fetus, for example, you do not do amniocentesis only of that fetus. You do amniocentesis of both the fetuses, because you're not sure about the zygosity, unless, of course, it's an IVF pregnancies, and two embryos have been transferred. So if you don't know the zygosity, then you have to do amniocentesis of both the fetuses, because although the second fetus may look structurally normal, it could have the same genetic composition as the other fetus. Now, the complication rate, of course, is higher in monochorionic pregnancies. You can see the mortality rate is as high as 30 to 40% compared to a dichorionic pregnancy, which is about 10%. Now, in twins, if you see, a monochorionic pregnancy is 6 times more likely to miscarry between 12 and 24 weeks. The perinatal death rate of FGR and preterm delivery before 32 weeks is 2 times higher, and the incidence of congenital defects in twins dichorionic is 1%, but it is 4% in a monochorionic pregnancies. So definitely we are dealing with high risk situations in a multiple pregnancy situation. And the incidence can be high due to previous multiple pregnancy. If you have a family history on the maternal side of having a multiple pregnancy, increasing maternal age, some races have higher incidence of multiple pregnancy, West African, Japanese, and of course in our context, assisted conception. Now, what is the role of ultrasound when we're dealing with multiple pregnancies? Of course, the first role of any pregnancy is to confirm whether the pregnancy is single or multiple, and we've had in the past so many kind of varied situations. This is, of course, very, very old slide where I could see 5 intrauterine and 1 was the cesarean scar ectopic. And here, of course, you can see 2 or 3 probably, and sometimes it becomes very difficult to know at an early stage which is a sac and which is a pseudo-gestational sac. So the next important thing is labeling. It's very important that you label from below, from the internal os level. That's the presenting fetus is usually the fetus 1, and then you go in an anti-clockwise or a clockwise, whichever rule you follow. We follow the anti-clockwise. So we say lower, left upper, right upper, and then we identify the placental location, and then you label the pregnancy abnormalities. Definitely look for Mullerian abnormalities in every pregnancy. Here's a vanishing twin in a septate uterus, vanishing twin fetus. This is a bicornuate fetus with a hemorrhage in one side and a fetus in the other, and you can see that on 2D and 3D. And this is a bicornuate uterus, again with a triplet pregnancy, which we reduced to a twin and left twins and delivered at 34 weeks. The third important thing, of course, and the most important thing, role of ultrasound is chorionicity. Now, chorionicity is very easy at about 11 to 14 weeks, but when the when the pregnancy presents early at 5 weeks, you can count the number of gestational sac, but that does not tell you the fetal numbers, because as you go ahead at 7-8 weeks, you may see that one sac may have actually 2 fetuses. Then 6 weeks, you can see the fetal numbers, and you can also see the yolk sac. So, of course, if you see 2 yolk sacs, you know this is a diamniotic monochorionic pregnancy with a single gestational sac. But a single yolk sac does not tell you amniosity. So even if you have a diamniotic pregnancy, you could have a single yolk sac, or if you have a momo pregnancy, you could have a single yolk sac. At 7 to 8 weeks, you can actually see the amniotic membrane. So not before 8 weeks can you actually talk about a single sac being diamniotic. And then, of course, we rely on the famous lambda sign, where you have proliferation of the chorionic villi in between the intertwin, which forms a triangle, or you don't have chorionic villi and it's a thin line separating the 2 fetuses. So here you see there is no separating line. Here this is a T sign with the thin membrane and no chorionic villus, and here you see the lambda here going up and separating the 2 fetuses with the thick membrane separating the 2 fetuses. So that's the lambda sign, suggesting that this is a dichorionic pregnancy. This is a monochorionic diamniotic, and this is a momo or a monoamniotic pregnancy. Now, of course, if there are more than 2 fetuses, then 3D can be useful, because you can see the entire map, and these are the delta signs here, and you can see thick membrane even at an early stage separating the 2. Now, you can also see the placental masses. So if you have 2 placental masses separate, then you know this is a dichorionic pregnancy. Sometimes the placenta will be continuous, and therefore it can be difficult, but you can see the delta sign, and you can also see that there is some separation, but this can be tricky. But more importantly, you see that there is a delta sign. So ultimately, we come down to looking at the delta and the T sign. Of course, in dichorionic pregnancy, they can be of the same or different genders. In a monochorionic pregnancy, they usually of the same gender, and because of our rules in our country, we cannot see the gender. Now, this is a dichorionic quadruplets, and you can see a thick septum or membrane separating the two sacs and thin membrane separating two fetuses on either side. So that's a T sign and a delta sign here. So that's a dichorionic quadruplet pregnancy. And you can see that here. So thickness of the membrane is also important. Thicker the membrane, that means there are two layers of chorion and amnion on either side. And when you have only the amniotic membrane, it is a thin line vis-a-vis the chorionic separation that you can see here. Now, this is a dichorionic triplet pregnancy. So that's the delta sign. One separate fetus here and two fetuses here separated by a thin membrane. So dichorionic triplet with a monochorionic twin. So very, very important that we do a chorionicity when we are checking a multiple pregnancy. It's not enough to say twins, triplets, you need to give the chorionicity. Now, dating of the pregnancy is usually done in the first trimester with a CRL, and it is done by the larger twin. So the larger twin dictates the gestational age of the fetus. So between 11 and 13 weeks, as I said earlier, we date with the CRL. After 14 weeks, we date with the BPD and the larger twin. And this is because if you date with the smaller twin, then erroneously your dates can be wrong if that smaller twin is small because of a smaller placental component. Or the larger twin will then be labeled as a large for gestational age. Some people believe in doing averaging. So you take the CRL of the larger and take the CRL of the smaller and take the mean CRL and then date it. But according to ISWA guidelines, the larger twin is the better twin to date, and then you will then monitor the smaller twin more closely because it is smaller in size. So this is one of the thinkings, and that's why we always stage on a larger twin. Now, how often do we scan in a multiple pregnancy? So we always start with the first trimester scan. We do a combined nuchal scan with biochemistry and dating at about 11 to 14 weeks. And this is the same for both dichorionic and monochorionic. In a monochorionic, we call the fetus back at about 16 weeks, vis-a-vis the dichorionic, which can come later by about 18 to 20 weeks. The follow-up in a monochorionic pregnancy is always every 2 weeks as compared to a dichorionic pregnancy, which is every 4 weeks. And of course, if there is any complication, then you can monitor more closely. And this is the ISWAG recommended flow chart. You start from 11 to 14 weeks, dating, labeling, chorionicity, screening for chromosomal abnormalities, and then scan in a dichorionic pregnancy from 20 weeks onwards. Every 4 weeks, we do assessment of growth, amniotic fluid, and all the fetal Dopplers at every scan, and attempt and delivery after 37 weeks. In a monochorionic pregnancy, you scan from 16 weeks. Every 2 weeks, we will look at detailed anatomy at the 20 weeks, biometry, the amniotic fluid, maximum vertical pocket, umbilical artery Doppler, MCA Doppler, and cervical length, and then follow up with growth, Leica, and the two Dopplers every 2 weeks. Now, what do we look for? As I said earlier, we look for biometry. Important that we look for discordance in fetal weight and then document that from the first and the second scan. We look at umbilical artery Doppler and we look at MCA Doppler to look for taps. We look for deepest vertical pocket for TTTS, and of course cervical length for preterm birth. Then how do we focus on aneuploidy screening in a multiple pregnancy situation? So generally, when we take the a priori risk, maternal age cutoff risk is 35 years in a singleton pregnancy. In a multiple pregnancy, we take it slightly lower as 31, and the cutoff is, of course, again 1:250 or 1:100, depending on your geographical incidence of Downs and your complication rate with invasive procedures. We screen with combined screening tests, that is the PAPE, beta HCG, and the nuchal scan. And if there is a vanished twin, and if there is yet a measurable fetal pole, then we don't do the combined test. We screen alone on the nuchal and maternal age. And same goes for NIPT. So if the NIPT has to be done, you need a minimum gap of at least 6 to 8 weeks before which, after the vanishing twin has disappeared or is been seen, and then only you do an NIPT. And here you can see that we rely mainly on the nuchal scan. These are twin pregnancy with one fetus having a nuchal edema and the other fetus is normal. That's a dicorionic fetus. But we will test both the fetuses. As I told you, that 1 out of every 7 dicorionic fetuses will be a monozygotic fetus. So it's very important that you test both. And the same standard first trimester aneuploidy signs of nuchal edema, reversal of A wave, and tricuspid regurg are looked for. So you look for abnormal nuchal scan, and of course you look for any abnormality and abnormality in growth. Now, what are the implications of the screening combined test? If you have high risk in monochorionic pregnancies, both are usually affected, and the risk is the same as a singleton pregnancy. The only difference being here that if you have an NT of 2 in one fetus and NT of 1 in the other fetus, we take the average NT. So 2 plus 1 divided by 2 will be 1.5. And that's how we risk estimate, because they have the same genetic composition. So you can have different nuchals, but we take the average of both nuchals. In a dicorionic pregnancy, we don't do that. Each fetus is individual, and it's got its own risk for having a congenital abnormality, which is twice that of a singleton. So the risk is double of a singleton. Here, the risk is the same as a singleton, but here the risk is double. So if you've got a 1:100 a priori risk, and if you have one affected fetus, then your risk becomes 1:50. If you have both affected, it becomes double, that is 1:10,000, that is 1:100 into 1:100. So the risk is usually double the singleton risk. Here the risk is the same as the singleton risk. Now, when we're dealing with detection of trisomy 21 as compared to the combined test, in a dicorionic pregnancy, your detection rate is 86% compared to the 90% detection rate of a singleton pregnancy. And a monochorionic pregnancy, of course, because they have the same genetic material, is about 87%. So roughly speaking, about 4% less than a single pregnancy for the same false positive rate. That means 5% of pregnancies which are normal, which will have unnecessary invasive tests. So that's the false positive rate. Now, when we do procedures, if you have a dicorionic pregnancy with a situation like this, where the placenta is fused, you will then take this at this edge and take this at this edge. And so you will move the needle further down here. Of course, if there are 2 placenta, then life becomes simple, and then you take 2 separate chorionic villus samplings. Important part to map the fetus, as I said earlier. So which is fetus 1 and which is fetus 2, because if you have an abnormality in one of the fetuses, you need to map it so that you can do a selective reduction of that fetus. Same thing for an amnio, only in an amnio you can go through the membrane. So you have one abdominal pass, you take a sample from here, then go through the membrane, take another sample from there. Or of course you can take 2 samples if you like, but I prefer this earlier method. The complication rate of procedures is slightly higher with multiple pregnancies. It is 2% following CVS and 1.5 to 2% following amniocentesis. Risk is the same for transabdominal and transcervical approach. Of course, we don't do transcervical approach anymore. We do only transabdominal approach. Whether you use a single needle or a double needle system, the risk is the same. And whether you use a single or double uterine entry. So, as I said, you use a double entry or a single entry, but preferably to do a single entry. When you have a monochorionic twin, you usually sample only one amniotic sac. especially if you have confirmed monochorionicity before 14 weeks, and if both the fetuses look normal and they are growing normally, then it's okay to do one sac. But if there is a discordant abnormality, that means one fetus is having a structural abnormality, then you may need to sample both the amniotic sacs, because very rarely you may have a different karyotype in both these fetuses because of mutation in a monochorionic pregnancy. So you need to sample both the sacs. If you're doing a chorionic villus sampling, you generally will sample only the single placenta. So there's a small chance that you may miss out a discordant pregnancies. And discordancy has been reported in a monochorionic pregnancies in all the trisomies, 13, 18, 21, Turner syndrome, and triploidy has been reported. You also have heterokaryotypic monochorionic pregnancies, so that both the pregnancies may have different chorionicity. Now, what are some of the problems we face with a monochorionic pregnancy? So monochorionic, of course, the one that we see very rarely in 1 out of 8,000 pregnancies, or 5% of monochorionic pregnancy, is called a MOMO pregnancy, monochorionic monoamniotic. You will have a single placenta, same sex, no dividing membrane, normal amount of amniotic fluid is seen around both fetuses. You may have a single yolk sac, and the cord insertion will be very close, as you can see here. So most of the times they will intertwine their cord as early as in the first trimester, and you can see sometimes they are so close. This one was sent to me as actually a conjoined twin, but actually you see two umbilical cords which were intertwined, and there was no conjoined twin here. So cord entanglement can be responsible for 50% of all losses of one or both fetuses. Many of the times, even if you see cord entanglement in the first trimester, they will go through and deliver at around 33, 34 weeks. But at other times, they can have a fetal loss. Fetal abnormality rate, especially cardiac and neurological, very high, almost 25%. Now, we don't see TDTS. It is less common in a momo twin. So essentially, what we would see is a growth abnormality rather than a TDTS. So the moment you have a monochorionic pregnancy, monoamniotic, the risk of having TDTS is almost negligible. But as the fetus grows, and if one is smaller than the other, one of the fetuses can compress the cord of the other, resulting in fetal death. And then, of course, we have a problem. And the premature birth rate is also high because of cord entanglement. So essentially, we try to deliver by 34 weeks, unless, of course, there's a life-threatening complication where we can consider delivery after 26 weeks, or even we consider a cord ligation in one of the fetuses if it is very small and getting compromised. So here, this is an early pregnancy of about 10 weeks, and you can see cord entanglement. And we put a Doppler, and you can see that you get two heart rates with two umbilical arteries flowing in different directions, or sometimes even in the same directions. You can see here there's entanglement here, and that tells us that this is actually a momo pregnancy. Now, when we're dealing with a monochorionic pregnancy, diamniotic, for example, we have three types of vascular anastomosis, and that can cause a problem. So we have the superficial arterial or venous, as you can see here, arterial, venous, and these are actually bidirectional and they are balanced anastomosis. So they don't usually cause a problem, they cause balancing of both the circulations. As compared to the third type, which is the arteriovenous, and there you will not see the connection on the surface. So it will dip into the placenta and then continue in the vessel on the opposite side. And this can be seen in 15% of monochorionic pregnancies. And the donor fetus will then unidirectionally supply blood to the other fetus, and that causes high drops in the recipient and the characteristic TAPS or TTTS. So this is very, very important to know. Now, you can have unequal placenta. So a fetus with a smaller placenta will develop selective fetal growth restriction. So in a monochorionic pregnancy, you can have SFGR. You can have acute transfusion of blood from one fetus to the other in the larger fetus. And there you will see that this is an acute transfusion. Hello? Can I call you later? I'm in a webinar, please. So this is, sorry about that. There is an acute transfusion, and this will result in spontaneous fetal demise in one fetus, and then the other fetus is at risk. So this will be sustained bradycardia in one fetus, which will ultimately demise, and then the other fetus will be at risk. So these are due to the fact of presence of arterial and venous, which can be large at times. And then, of course, because of these shared circulations, you can have discordancy of the discordant malformations because of the splitting of the embryo. And as I said earlier, in 15%, you can have unidirectional flow, and this will result in unbalanced transfusion, resulting in TTTS and TAPS. So let's look at some of these. So when we talk of discordant anomalies, you can have a varying range. It can be both in dichorionic and in monochorionic. And as you can see here, this is a twin pregnancy, one fetus with a widened brainstem, and we could see spina bifida and hydrocephalus. The other fetus was absolutely normal. Now, this is one fetus, twin pregnancy, dichorionic, with one fetus having a congenital diaphragmatic hernia as seen as early as 12 weeks. So we could do a reduction of this fetus. Now, this is 17 weeks, dichorionic. You can see a cleft lip palate in one of the fetuses, and the other fetus was absolutely normal. This is again a fetus with an omphalocele. The other fetus is normal. So multiple abnormalities can be varied abnormalities. So we need to test both the fetuses, as I said earlier. Now, this is a dichorionic twin again, where it's actually a dichorionic triplet, with one of the fetuses showing nuchal edema, the other fetus showing a kyphoscoliotic abnormality, and the third fetus showing a normal nuchal scan. So this needs to be tackled appropriately. Here, one fetus having a skeletal abnormality of a club hand, and the other fetus here showing a ventral wall defect, a limb body wall complex. So multiple abnormalities. So this is a dichorionic fetus with one fetus showing here abnormalities. Similarly, you can see this in both in monochorionic and diamniotic. This is a monochorionic pregnancy with one fetus is anencephalic, the other was normal fetus. And this is again an autosomal recessive condition in a dichorionic pregnancy where one fetus had the Harlequin syndrome and the other fetus was absolutely normal. And we could pick this up antenatally because of the presence of small feet with fixed contractures and, of course, prominent eyelids, and as you can see here, and prominent mouth seen here. So this is a dichorionic pregnancy. Then you can have unequal separation and in a monozygous fetus. So these are, of course, separate. These could be a conjoined twin if the separation is late. You can have a small separate trap fetus, so external acardiac. You can have a fetus attached to another fetus, a parasitic fetus, and a fetus inside another fetus called the fetus in feto. Now, when you deal with conjoined twins, they could be various. It could be a complete cephalophagus, a thoracophagus, an omphalophagus, which is probably the easiest to separate, and also the ischiophagous, as you can see here, craniophagus. So different depending on the rachiphagus with the spine, and just the buttocks again, which could be easy, a pyophagus. So some you can pick this up as early as 8-9 weeks. You can see two heads, and what you see is inseparable fetal contours as early as 6 to 8 weeks. They will remain unchanged relative to position of both the fetuses. Both the fetal heads are persistently at the same level, and of course the clue is that you have a single umbilical cord. So that's an omphalophagus with a thoracophagus. With a single heart out there, you can see there is sharing completely with a single umbilical cord. So that is the hallmark, and of course there are other abnormalities in the fetus which is larger here. Now this is about 10 to 12 weeks. The clue, as I said, is a single umbilical cord rather than an intertwined entangled umbilical cord that you see in a momo pregnancy. So that's a thoracophagus and both the fetuses are showing nuchal edema because of the shared circulation. Now, this was about a 17-week fetus, which shared the very small communication here. You can see at the lower abdominal level, there's a single umbilical cord dividing into two iliac arteries, and that's the liver on either side. So like an omphalophagus, but very easily. And what we could see that this was a pivot, and in fact, both the fetuses were rotating 180 degrees separately around this pivot. So that is interesting. This was a pediatric scan, and it came to us directly, and below the liver you can see that there is a teratoma or a fetus in feto, completely formed fetus below, and this of course has been seen antenatally, but in this fetus, of course, in this child, of course, it presented postnatally. And this is an ectoparasite, or can be called a small form of a conjoined twin, where you have a small component of the fetus here which is fused rather oddly here. So the other complications that we see which are more problematic is, of course, TOPS, TAPS, and TRAP, which we see in monochorionic fetuses. And these are due to chronic fetal transfusion of blood. So TTTS by definition is called as TOPS. That means we must see oligo-polyhydramnios sequence. Oligo in the donor and polyhydramnios. If we don't see this, we cannot call it as TTTS. In TAPS, you may have a smaller and a larger fetus, but you don't see oligopolyhydramnios, and the only way of diagnosing a TAPS is due to inter-twin hemoglobin differences. So we will actually see a anemic fetus and a polycythemic fetus, and we rely on the MCA Doppler. And of course, a TRAP, as I said earlier, is a small acardiac fetus which receives blood supply from the pump twin of the other fetus, that is the donor fetus. And this is seen in about 1% of monochorionic pregnancies, and it's quite rare, and you can have umbilico-arterial collaterals. Now you have, this is the pump fetus with polyhydramnios. You have umbilical flow going in the upward direction towards the transducer, and in the trap fetus you see that the umbilical flow is going towards the fetus and not away as normally see. And it's an incongruous mass. You see some fetal parts. These can be missed quite commonly if it is very small. So the moment you see a polyhydramnios, you start hunting for anything that's wrong, and you will see that there is a trap fetus. You won't see a fetal heart. You will see some vessels receiving blood supply from the opposite side. And this threatens the supply of the pump twin because it is stealing blood from the pump twin into the trap fetus, and this is appearing as a space-occupying mass. And as I said earlier, the complication is as high as 35 to 55 or 40%. Sometimes we don't see it in the first trimester, and it presents late because the sharing is less ominous, and you can see as late as 35 weeks. In fact, the pump fetus was absolutely normal, and this was a fetus seen at 35 weeks, which delivered after a normal fetus. So if the complications have to happen, they will usually happen in the second trimester, early second trimester, 16 to 20 weeks. After 26 weeks, usually there will be no complication in this pregnancy. So if at all we see them early, we treat them, and sometimes they are missed. The second problem that we see with monochorionic pregnancies is a discordant growth because of a smaller placenta in one fetus compared to, and this can happen both in dichorionic and monochorionic pregnancies if you have unequal placental sharing. And you may see a single umbilical artery, you may see a valomentous insertion of the cord, or as you can see here, the dichorionic twin with a smaller sac and a smaller placental component. Of course, the placenta looks fused, continuous, but you can see that the membrane is thick. There is a delta sign, and you can see the delta, and this is a smaller sac, smaller placenta as compared to bigger placenta, and therefore this fetus has a higher chance of developing a selective growth restriction. And this is a monochorionic pregnancy with a valomentous insertion of the cord, and therefore higher incidence of a selective fetal growth restriction. Now, CRL discordance of more than 25% or even 10 millimeter in the first trimester can indicate the possibility of a selective fetal growth restriction, which may manifest late. it may not be as accurate to indicate a twin-twin transfusion syndrome. So CRL is a disparity is not positively correlated with prediction of TTTS. It can positively correlate with fetal loss, but again, the correlation is not very, very good, about 52%. But what is most important is that if there is a discordance of even more than 10%, or if there is an NT discordance of more than 20%, then the chance of having fetal abnormalities is very high. So although the discordance of CRL can indicate the presence of selective growth restriction that may manifest later, we must screen these pregnancies very, very carefully for chromosomal and other abnormalities. Once the fetus grows, then how do we describe fetal birth weight discordancy? We can either describe it by fetal weight. So if the discordancy is more than 15%, we call it mild discordancy. If it's more than 30%, it is severe discordancy. And you can see here the growth chart shows the discordancy in two fetuses. You can also look at abdominal circumference, and if the discordance is about 18 to 20 millimeter in the circumference, then that is also a discordant growth. Now, how do we define growth restriction? As you know, we have the definition of first singleton pregnancies by the Delphia method, which has been well established. In a twin pregnancy, both dichorionic and monochorionic, if you have a fetus which is below the third centile, then that is a growth restricted fetus, if the fetal weight. Or if you have contributory at least two out of these three. So if you have a fetal weight which is less than the 10th centile, you have discordance of at least 25% in the fetal weight. Or if you have the umbilical artery Doppler, which is higher, more than 95th centile in one fetus. So for example, you have a twin set here, which is growing below the 5th centile. Both the fetuses are below the 5th centile, as you can see here, 2.5 centile, 1.1 centile. And one fetus has an umbilical artery Doppler, which is way above, that is above the 95th centile. The other fetus has below the 95th centile. And you can see 28 weeks, one fetus having reversal of flow. MCA shows high flow, CP ratio is less than 1. The other fetus has low diastolic flow, but MCA flow is also low diastolic, and CP ratio is more than 1.1. So definitely this fetus is at higher risk and of having a problem. Now, as we followed up these fetuses, you can see twin 1 was growing. Both the fetuses, this one was larger, 1.3 kgs, this was 1.2 kgs, but you can see here this fetus is developing reversal of flow, whereas here diastolic flow is yet present, ductus venosus is normal, but the CP ratio has fallen to about 0.4, so extremely high. They are about 29 weeks and 31 weeks. The larger fetus is 31, 29, so we may consider a delivery in this kind of situation. Now, when we're dealing with a monochorionic fetus with selective growth restriction, we have three types of umbilical artery flow that we will be seeing. One is if the Doppler is showing either normal or high resistance, and this is called type 1. This will not change. It will remain the same. The other fetus is got either absent or reversed end diastolic flow, which is persistent, is called type 2. And here we don't have a high risk of unexpected IUFD, but 90% will deteriorate, and therefore you need to monitor closely and deliver after 30 weeks. The third type is called the intermittent absent reverse end diastolic flow, and this can be very tricky because you need to monitor the Doppler over a period of time, because early you may see reversal and you may stop, but after some time the flow may come back, and this will not deteriorate as much as type 2, but unexpected fetal loss rates are very, very high, and these are usually the types which have large AA connections, and they will lead to spontaneous demise of one of the two fetuses. So in both these categories, you have to be very vigilant, and you either offer expectant treatment and continue and deliver early, or if the situation is worsening, then you do a cord occlusion or a laser separation of both these fetuses, or sacrifice one fetus and do a cord occlusion. And you can see here this fetus was having absent intermittent reversal, again coming back, but essentially absent to reversal, and the other fetus is having a normal umbilical artery Doppler, and this one fetus is at high risk. So we can have two groups of presentations, early growth restriction and late growth restriction. In late growth restriction, the mortality is low because usually we can deliver and we can manage these fetuses. The problem is always in the early growth restricted fetus. So when you see a monochorionic fetus with selective growth restriction before early onset, before 26 weeks, then the mortality is as high as 15%. You will see abnormal umbilical artery Doppler, unequal placental sharing, and you will see large AA anastomosis. In the late onset, after 26 weeks, the mortality is low. The Dopplers may be normal. You could have normal placental sharing and tiny anastomosis, AA anastomosis, because of which they presented late. So how do we deliver in a twin pregnancy with selective growth restriction? In a dichorionic pregnancy, we should not deliver till about 30 weeks. So we deliver after 30 weeks. If you've got ductus venosus reversal, that means the fetus is at high risk, you deliver at 30 weeks. If you've got umbilical artery reversal, deliver between 30 and 32 weeks, even if the ductus venosus should be normal here. And 32 to 34 weeks if there is absent of diastolic flow with a normal ductus venosus. And of course, if you've got a low CP ratio, you deliver after 34. So we don't wait after 34 weeks in a dichorionic pregnancy with a low CP ratio. What about monochorionic pregnancies? So generally in dichorionic, we avoid delivery before 32 weeks, even if one fetus is smaller, in the interest of the larger fetus, because we may have prematurity in the larger, we try to avoid delivery before 32 weeks. In the monochorionic fetus, if there is a substantial risk of fetal demise in the smaller fetus, if you've got ductus venosus reversal, and if you're before 26 weeks, we will consider selective termination of one of these fetuses. If you're after 26 weeks, we will consider early delivery. Again, as I told you earlier, if it is type 1 Doppler flow, you will go to 34, 36 weeks. If you are type 2 and type 3, it depends on whether it is before 26 or after 26. Now, sometimes there may be oligopolyhydramnios with FGR. So you have FGR and TTS both occurring together. And the management will not be affected by the presence of TTS. So the treatment will be the same. You can do a laser separation, and the overall survival will be the same if you have SFGR with TTS. The survival is the same, or the smaller twin survival is 40%, the larger twin survival is about 70%. So immaterial. So like here, you have a monochorionic pregnancy with a smaller stuck fetus here, a larger fetus with a distended bladder here. You can see there is absence diastolic flow in this fetus, presence of diastolic flow in this fetus, and this fetus, the larger fetus, also has a pulmonary stenosis, which is a common complication. Now, the disparity in fetal weight was, one was 19 weeks, one was 16 weeks here. This is 60th centile, this is less than 1 centile. And you can see the amniotic fluid is 7.38 and 4. Now, in TTTS, the definition is that you should have more than 8 centimeters maximum vertical pocket and less than 2 centimeters maximum vertical pocket in the donor fetus. So this is not yet oligopolyhydramnios. This is selective growth restriction in a monochorionic fetus. But as we follow up after 1 week, you see 19 weeks, the twin 1 now has a LICA of 8.3 and twin 2 yet has 4. So it is progressing to a TTTS. So SFGR, and you can see that the weight discrepancy is also there, and the pulmonary stenosis is worsening. So we need to do something here. We need to do either a laser separation or sacrifice the larger fetus because it has a pulmonary stenosis. Or sometimes the pulmonary stenosis may reverse if you do a separation. So what is the management of complicated twin pregnancies? We would either do a conservative management with early delivery. As I said, if it is after 26 weeks, we would do a laser separation or a selective cord occlusion of the smaller fetus. Now, finally, coming to discordancy of Leica. When we know that the oligopolyhydramnios situation is there, this will be seen in about 15% because of the unbalanced AV communications. This is TTTS. Now, can we predict it in the first trimester? Unfortunately not. The increased NT, the CRL discordancy, even Doppler discordancies has not proven to be very useful. Of course, they tell you that you need to monitor these pregnancies, but otherwise, essentially the diagnosis is made after 16 weeks. You have a single placenta, discrepancy in amniotic fluid, as I said, oligopolyhydramnios, bladder is not seen in the donor, fills up in the recipient. You have a discrepancy in the fetal size, which can be as high as 20%. You can have edema of the cord of the recipient fetus. You can have cardiac failure in the recipient fetus with pulmonary stenosis and right ventricular hypertrophy, or you can have abnormal Doppler. And that's when we use the Quintero's classification. So stage 1 is oligopoly. Stage 2 is absent bladder in the donor. Stage 3 is abnormal Doppler, that is the umbilical artery shows absent diastolic flow, and the ductus venosus of the recipient shows reversal of A wave. And stage 4, of course, is hydrops, either in the donor or the recipient, and stage 5 is demise. So as I said earlier, less than 2, more than 8, amniotic fluid, absent bladder, large bladder, the mobility, the smaller fetus is stuck, so you turn the mother onto any side against the side of the smaller fetus, and that fetus won't fall with gravity, and therefore it has an amniotic membrane, and this is not a momo fetus, and the recipient fetus will of course move freely. As you can see here, polyhydramnios, bladder, this is stuck fetus, smaller fetus, and here you can see that there is oligohydramnios with the membrane here, and the larger fetus has polyhydramnios. And then, of course, the discrepancy in fetal size, as I said earlier, you can have more than 20% discrepancy. You can also have BPD difference of more than 5 millimeter, or the abdomen circumference difference of more than 20 millimeter in the smaller and the larger fetus. And you can see type 2, distended bladder, no bladder here, thickened umbilical cord with polyhydramnios. In fact, the larger fetus jumps around and is actually squashing the smaller fetus, or the smaller fetus may be stuck on 3D. You get some dynamic pictures. It's as though this fetus is carrying the burden of the smaller fetus. And stage 4 will be, of course, Doppler, where you will see a difference in the SD ratio of more than 0.4 between the two fetuses, increased resistance in the umbilical artery in the donor and the recipient, absent and reverse diastolic flow only in the donor fetus. In the recipient fetus, you can see reversal of flow in the ductus venosus, and also the umbilical vein will show alteration. So this is severe tricuspid regurgitation. You can see right ventricular hypertrophy. The tricuspid valve is getting thickened, and there is ductus venosus which is showing reversal. And here the umbilical vein artery is showing absent diastolic flow. So management is, of course, if you have above 30 weeks, you can deliver. Below 30 weeks, you can have expectant management in stage 1, and stage 2, 3, 4, of course, we do laser. If you don't have option of laser, you can do a reduction amniocentesis in the recipient fetus. This will lead to lower survival rate of about 50%, but it's the best you can do if you don't have laser, and about 33% both would survive. Babies will be born prematurely, of course, and at about 30 weeks. And this is because you're not correcting the physiological vascular disturbances. You're only reducing the chance of preterm birth by reducing the amniotic fluid in the larger fetus. And there is a high risk of neurological abnormality in the survivor because of the unequal vascular communications, so as high as 20 to 30%. Now, the fourth component or fourth complication of shared placenta will be discordant perfusion, not discordant Leica, but this is TAPS and single fetal demise. So as I said earlier, if you have large AA communications, and if you do an MCA Doppler, you see increased velocity in one and lower peak systolic velocity in the other, you know you're dealing with TAPS. It's not a very, very common condition, fortunately, but we do see it post-laser. So it is characterized by intertwin differences. So in the recipient fetus, you have a PSV which is less than 0.8 MOM. 1 MOM is normal, and in the donor fetus, the peak systolic velocity in the middle cerebral artery is more than 1.5 MOM, and that suggests that there is an inter-twin difference in hemoglobin of more than 8 grams percent, which leads to a TAP situation. And this is because there are slow transfusion happening from one fetus to another due to smaller caliber AA anastomosis, and you don't see amniotic fluid disturbance. And this can also be seen after a laser separation because small anastomoses are left behind. You have not coagulated small anastomosis. And the differential diagnosis is, of course, acute fetal-fetal transfusion, which results in single fetal demise because of large AA communications. And you can see these are small communications which are not ablated with laser. So essentially, you can see it accidentally post-laser or in the neonatal stage. And here again, you have 4 stages. When you're talking about Quintero staging, I must say that one stage may not progress to another. You may see stage 1 on one day and suddenly stage 4 on the other day, as compared to TAPS, which you may see all the stages. Because in stage 1, you have mild anemia. Stage 2, the anemia is progressing 1.7 in the donor. Stage 3, you have cardiac compromise in the donor, and therefore it will lead to hydrops of the donor. So this is as compared to the TTTS, where you have hydrops in the recipient. And of course, stage 5 is intrauterine demise. The treatment, of course, is expectant and deliver after 26 to 30 weeks, or you give an intrauterine transfusion, which is a problem because when you give an intrauterine transfusion to the small fetus, it may ultimately go to the larger fetus and cause more polycythemia and worsen the situation. So we prefer to give an intraperitoneal transfusion. Again, laser surgery is difficult because there is no polyhydramnios and the communications are very small and may not be seen. So both these managements are very tricky in a TAPS situation. And this was a post-laser situation where the Leica kept increasing in one fetus and the other fetus was yet stuck, and the MCA Doppler started showing higher flow as compared to the other flow suspect for TAPS developing in this particular situation. And the last complication of a multiple pregnancy is, of course, intrauterine fetal demise. And we always shirk this possibility whenever you see a monochorionic fetus. The perinatal mortality, as you know, in twins is 5 times higher than singleton. And this is a complex situation. It depends on the chorionicity. Of course, if it's a dichorionic pregnancy, then that's not a problem. If it's a monochorionic, then we can lead to loss or mortality or morbidity in the second twin. We could have neurological abnormalities. We could have mortality in the surviving twin. And again, it depends at the gestational age, at the diagnosis, and what is the cause, whether it's monochorionic, dichorionic, post-laser. And if it's a dichorionic, we do see spontaneous loss very early. And this doesn't really affect. Even in a monochorionic fetus, if you have a spontaneous vanished embryo early, then the other fetus may continue and may not lead to a problem. But in most other situations, after 20 weeks, it would depend on the chorionicity, the degree of vascular anastomosis, and the presence of TTTS. So how do we approach this? If you have a single fetal demise and it is continuing, it's a dichorionic specific to deliver at term. If the insult has resolved sometimes, you give steroids and magnesium. And if it's a dichorionic pregnancy, you monitor on a weekly basis and deliver after 34 weeks. In a monochorionic pregnancy, after 28 weeks, we would deliver. Before 28 weeks, you may see intracranial pathology, and of course that's a bad prognosis because in Western countries they can consider feticide, but in our country we are not allowed to do feticide. If you don't have any intracranial pathology on MRI, then we are very, very lucky. Then you deliver at 37 weeks. And this is some of the fetuses. You may see vascular complications like subependymal cysts. This is a fetus which developed a large leukomalacic area And this fetus, of course, unfortunately, this is one fetus which spontaneous demise, and the second fetus bled massively into the other fetus. So there's a big problem. So as I said earlier, we do monitoring every 2 weeks, fetal MRI after 4 weeks, and if you find anything abnormal, then we have a bad situation and we deliver at 34 weeks or earlier, depending on when we see the problem. So management is, of course, corticosteroids for lung maturity, neuroprotection with magnesium, with a pediatric consultation. You usually do a cesarean section if it's a malpresentation. We look for coagulopathy if there is more than 4 weeks of a dead fetus, and of course the psychological issues that come into play. Very, very important that you look at the cervix, because if the cervix is opening up, then, and if it's less than 2.5 millimeter in 25 millimeter, then we know that we have a high chance of preterm birth. So how do we monitor a multichorionic pregnancy or a monochorionic pregnancy? We start at 12 weeks. 20 to 28 weeks is the chance of severe complications. I told you earlier, every 2 weeks we look for TDTS, selective growth restriction, anomalies, and management appropriately. After 30 weeks, the late complications can happen, but at a lower rate, and we can do an amnio reduction also if necessary and deliver at an early gestation. So the bottom line is that when we do ultrasound, it's not a twin pregnancy. We have to characterize the chorionicity as MOMO, MCDA, or DCDA. We establish the chorionicity in the first trimester, look intensively for growth monitoring, look for complications between 16, 18 weeks, 28 weeks, and 30 weeks, and thereafter we consider delivery. So that's the end of my talk on multiple pregnancies, and we have about we are overshooting the time, so should we go straight for the talk on interventions, or would you like questions?
Yes, SLCS team, please reply.
Hello?
Yeah. We have a couple of questions ready, but if it's, we can ask actually after you. How long will the next presentation take?
I think I will. It is actually a half an hour, but I will try and make it 15-20 minutes if possible.
Okay, shall I ask the questions after that, or?
Okay, so
we'll continue and we'll answer that.
Okay. So ultrasound guided fetal interventions is the most challenging thing when we are doing fetal medicine. Of course, fetal treatment was born from clinical frustration. I like the statement made by Peter Callan in 1984. We used to many times get these hydropic fetuses, and they were anyway going to get terminated. We gave blood transfusions, saved some of them, and that's how fetal medicine was born. So the motto, of course, is do no harm. You must be very well equipped to do these procedures. Now, you can have therapeutic procedures and diagnostic procedures. The diagnostic procedures, of course, being the CVS. As I told you earlier, this is the indication when we do, and I'll not go through this again, but very, very important that we use proper sterile techniques. This is by far the most important image that you need to see lower down on the right. The needle, we use standard needles, spinal needles for diagnostic procedures. The transducer and the needle should be at 90 degrees angle to each other and 45 degrees angle to the midline. Only then you will see the needle going in below the transducer and you will see it. Now here you see aspiration cannula, a sterile cover for the probe, and sterile, the mother is prepared, and then we give local anesthesia sometimes if the mother is anxious. We do give atropine prior to the procedure, a mild sedative, an antibiotic cover. We use tocolytics, and of course if the mother is Rh negative, we do an anti-D, and patient is advised to remain 4 hours of fasting, and that's the needle as you can see here, and the same principle is used, and under ultrasound monitoring the needle is guided in at a 45 degrees angle to the vertical. When you do a chorionic villus sampling, it is between 10 or 14 weeks, you can see the needle coming through in the chorionic tissue. We take 4 or 5 passes with suction maintained in the syringe, and it is done with an 18G needle. We take about 20 grams of tissue, normally comes in, minimum requirement. And amniocentesis, of course, done after 15 weeks. This is done after 10 weeks, 10 to 14 weeks. We use a 20 to 22 gauge needle. A swift pass is done. You see the needle, and it has to be very fast, and no jerking at that side, because that's the membrane where you can cause leaking. And we aspirate about 20 cc's. We do cytogenetic analysis, FISH, QF-PCR, microarray, DNA analysis for conditions like thalassemia, Duchenne's, viral infections, etc., hemophilia, and of course storage disorders. You can do enzyme analysis. Now, this is just to show, again, if you have an anterior fundal posterior placenta, it becomes easy to do a CVS. You can see 4 or 5 passes, and that's this is a molar pregnancy. You can see that's an amniocentesis. Now, what's important is that sometimes the placenta may not be accessible. Here, of course, this is a good accessibility of the placenta. Here again, it's a posterior placenta, so you go in. That's again a good placenta. This placenta is very low here anteriorly, so you have to go through the myometrium into that side. But what's important is if it's a posterior placenta, you may sometimes have to, with the transducer, push the uterus up, and I'll show you how we do that. So that's a posterior placenta. Here you can't pass the needle directly, so what we do, we push the uterus in front and bring that placenta in line, and then we pass the needle and we take a sample. So that you can see here. That's the needle going in and the sample is taken here. So same placenta, which was earlier like this, you're moving it. So we use these techniques, and no placenta is inaccessible to a transabdominal CVS. And sometimes you can use a color Doppler to see, avoid for vessels, as you can see here. You take a sample from this area. And as I told you earlier, this is what we do in multiple pregnancies. You can sometimes go through the membrane and go through the opposite sac and take the amniotic fluid. So you take one from here, one from there, and you can do that. Now, we analyze the tissue on a Petri dish. You see branching villus pattern, and you use either normal saline with a little bit of heparin, or you use the Boyne's fluid provided by the laboratory, as you can see here, and examine the sample and then send it. Now, I told you earlier, the complication rate is very low, 0.22 and 0.11%. And the only problem with the difference between CVS and amnio is that there can be maternal cell contamination on CVS, which is as high as 1.9 to 3.8%, as compared to amnio, which is less than 1%. The other problem is mosaicism, that is maternal cells coming in, or this is maternal cell contamination. You may see in the placenta different cell lines, which is called mosaicism, and therefore you may have mixed cell lines in about 0.6 to 0.8, and this does not happen in a very high incidence in amniocentesis, because basically you're dealing with only fetal cells which are shed, and this mosaic pattern is very, very low. The complication, of course, of both these procedures can be bleeding, amniotic fluid leaking, very rarely infection because we are giving antibiotic cover, and of course sometimes if you have an Rh antibody situation, you can have fetal-maternal transfusion and exacerbation of the Rh situation. The third procedure we do is chordosynthesis, after 16 weeks, essentially for anemia, infections, or if there's a mosaic pattern that you see, or if there are late presenters. So we go directly into the cord. If it's an anterior insertion, you can see the needle going directly into the umbilical vein. We never target the umbilical artery. The umbilical vein is the larger vessel, and it can be done either transplacentally or transamniotic if you have a lateral insertion of the cord, or if you have a posterior insertion of the cord. So this, of course, a little more complicated procedure, and the complication rate is higher. I'll not go through it except to say that 5% complication rate that we see, fetal loss rate, 1 to 5% as compared to other procedures. So we do it only when really necessary, when you're doing a fetal blood transfusion, and that's when we do a chordosynthesis. The other procedures that we do are, of course, multifetal pregnancy reduction. We sometimes put shunts, and then, of course, in monochorionic pregnancies, we use laser. So I'll have to quickly go through this. The most successful procedure, of course, is an intrauterine blood transfusion. I'll not go through the theory part of it, except that when you have, we usually like to go in a pre-hydropic state, not necessarily when there is hydrops. So we rely on the MCA Doppler in a mother who's got a history of Rh negative pregnancy, or if she's had a previous loss. We locate the MCA, correct the velocity angle correction, and if the velocity is more than 1.5 moms, then we know there is severe fetal anemia. And there's an easy way of doing this. We look at if the fetus is 20 weeks and if the velocity is more than double, that is 40, then we know this is more than 1.5 moms. And then we will go in and give a transfusion of maternally compatible. I will skip all this. And this is ORH negative blood that is given, which is compatible with the mother. It is CMV HIV screened. It is irradiated, and we go through the umbilical, either transplacentally or into the umbilical cord, and you can see the RBCs moving. We calculate the volume of blood to be given by these calculators that we have on the fetalmedicine.org site. And you just put in the donor, you put in the MCA Doppler, you put in the donor hematocrit, the fetal hematocrit, and it will tell you how much blood to transfuse, essentially about 100 ml in each situation. And then this is the most successful fetal procedure because the survival is as high as 80%, specifically if it's a non-hydropic fetus. If it's a hydropic fetus, the survival drops to about 60%, and then we deliver about 34 weeks. But each transfusion has to be followed up by successive transfusions every 2 weeks because you have a hematocrit which falls 1% every day. So that's a hemoglobin fall of 0.3 grams per deciliter per day. Now, you cannot use MCA Doppler, especially after 2 to 3 transfusions, because you replace the fetal RBCs with maternal RBCs, and the MCA Doppler is therefore no longer accurate in that particular situation. Now, this was a fetus with cardiomegaly. That's the transfusion going on here. And you can see post-transfusion, the heart size becomes smaller. You have the hydrops, which disappears in about 1 or 2 weeks. You can see post-transfusion, the hydrops is less. The polyhydramnios is yet there. And the Dopplers immediately are lower. And then 1 week later, again, it is increasing, suggesting that you need a Doppler. Ductus venosus was initially showing reduction of A wave, and subsequently post-transfusion, the PI has fallen to 0.41. So this is the most successful procedure. The other procedure where you may need a transfusion is a chorioangioma. Of course, we prefer laser ablation. So when you have a chorioangioma, it's easier to pass a needle, pass a laser fiber, and burn these vessels, as I'll show you later. So this was, of course, a fetus who presented very late with ORH negative mother, anti-D taken. There was a chorioangioma, and we just wanted to give a top-up transfusion. The fetus was hydropic, and we gave a little bit of transfusion and delivered this fetus in a couple of weeks, 1 or 2 weeks. So in this situation, the parents, because it was a late presenter, almost I think 30 weeks, they did not opt for a laser situation. The other procedure that we can do very successfully, although the results are not that good, is a putting in of a shunt. Now again, I will skip the theory for want of time. It can be done from 12 weeks onwards. You have smaller shunts. This is the Somatec shunt, specially described for 12 weeks. But usually we do it at a later stage. You can use these shunts for lower urinary tract obstruction, for large cysts in CCAM, and also for pulmonary effusions, primary pulmonary effusions. We aspirate the bladder, confirm that the fetal urine is showing good renal function. The appearance of the fetal kidneys is good, and it's not dysplastic. Liquor may be less. And then you may need to do an amnio infusion before you do the shunt. And essentially after 18 to 20 weeks, we would put in the double pigtail, you have the rocket type, which has got the orientation which is different. This goes into the fetal bladder and this stays out. And here, this is the Harrison shunt, which is both the orientation is similar. The rocket shunt is, of course, better, and that's the shunt. This is the plunger. So what we do is that we load the guide wire onto the shunt, and that's the plunger. And then we push that whole assembly into the trocar. This is the guide wire which is loading that pigtail. It is then loaded into the trocar cannula. You can see we straighten out the shunt, and this is loaded onto the trocar. And then with the plunger, we will push the whole assembly, and this will result in the shunt getting dislodged. And I will show you that in a minute. You can push the plunger and we dislodge. This is the plunger that has a point till which, so the first black dot will be in the fetal end, and then you withdraw the catheter, and the second point will be at the, you push the plunger again, and this will result. And so that's how we do it. This is a needle guided procedure. Use a 16 to 17 gauge needle. That's the whole assembly which goes in with the plunger in place. And I will quickly switch through there. And you can see that you have reached the fetal bladder. You are dislodging one end of the shunt. You're pushing that's the shunt coming in. And the other end of the shunt is then kept outside the fetal abdomen. That's the other end of the shunt you'll see in a minute here. That's the other end. You can see you. And then you withdraw the trocar and cannula. Now, the problem is that many times the fetus will remove the shunt and the shunt will get dislodged. Also, you're not allowing the bladder to empty. So bladder dysfunction is a problem, although you're relieving the obstruction and therefore relieving the oligohydramnios, the lung status will improve. But overall, you're not relieving the bladder status, and most of these fetuses will land up with renal failure and will require a transplant. Now, this is a new procedure, the lower urinary tract obstruction fetendo with a fetoscope. We have not started yet doing it. There are some centers in India which have done 1 or 2 cases. Basically, with the laser and a fetoscope, you go and widen the posterior urethra, just like you will do. And in about 40% of cases, you will have renal failure, and 40% of cases you will have good renal function post utero. So theoretically and practically, it's a good procedure, and you need some training. The shunts can, of course, be used for CCAMs, and sometimes we aspirate large shunts here. As you can see, this is a large CCAM. You aspirate it because you may land up with hydrops, but these can recur. So if you're very close, this is about 26 weeks, you can just aspirate it and leave it and maybe do repeat aspirations also. If you've got a primary pleural effusion, that is, there is no cause, so it's a chylothorax, you have done a detailed evaluation, anomaly scan, echocardiography, karyotyping, infection screen, then you can go and put in the sham shunt in the thorax. And sometimes we just aspirate. In this particular fetus at 30 weeks, we only aspirated once and it never recurred. And you just put in a needle and you aspirate this, and there was good resolution. We limited the lipid intake of the mother. She had chylothorax, and we found that she was consuming a lot of lipid, and therefore there was a good outcome. The third procedure, which is very, very easy to do, is of course an embryo reduction. I'll again skip the theory part. Best time is 11 to 14 weeks. We do an anomaly scan. We look for abnormal fetuses. This was a quadruplet, one trapped fetus. One fetus had anencephaly, and one fetus had a spina bifida, as you can see with a meningocele. So we reduced 3 fetuses and left 1 fetus behind. This was again a bicornuate, and I will just go, we map the fetuses, we select the smaller fetus, or if there is an abnormal fetus, and we take the smaller fetus here. And of course, if there is chorionic villus sampling done, then we will take the abnormal fetus in that particular situation. This was a monochorionic fetus, the lower fetus, which we reduced. We always reduce monochorionic. This was a quadruplet. So the needle goes in, essentially a 22 number needle. You go into the fetal heart
and you inject KCl, diluted KCl. We always do it transabdominally, never transvaginal. Same principles as I showed you earlier, 22 Gs. We either use diluted KCl or a few drops of lignocaine. Even lignocaine works as well as KCl. So you go to the fetal heart, inject a few drops of diluted KCl, and it can stop the car. Obviously, you cannot do it in a monochorionic pregnancy. So in a monochorionic pregnancy, we either use intrafetal laser needle procedure with radiofrequency ablation or fetoscopic guided bipolar cord coagulation or laser separation. Now, laser is done between 11 and 16 weeks. Cord occlusion after 16 weeks. RF ablation can be done at 14 weeks. Survival rate is the same, about 80%, and 20% of these fetuses can have preterm birth, 20% can have PPROM, premature rupture of membranes, and 15 to 20% can have neurological sequelae. So you need to do good counseling. We use a 17 to 18 G needle. We use a 400 to 600 micron fiber, laser fiber, and we use about 40 watts of ND YAG laser energy. So this is a twin, monochorionic twin with one small embryo. The parents wanted only one. We go in, and that's the burn we cause. It's simple. Just like we inject KCl, we pass the laser fiber, and we burn the cord insertion site into at the lower end of the abdomen. And you can see that bright area which is developing here is the site of the burn. And this can be used for both reduction. That's the needle going into the lower fetus here, and then it's causing the burn. Or we can use it even for a trap fetus. Now, this was a trap. You can see here we are burning, and I switched on the color to show how the energy gets transmitted. And that even for the trap fetus, you go in and burn the vessels in that situation. So you burn these vessels and cause a complete stoppage of the circulation. I'll move the video ahead. And that was a dicorionic triplet with a trap fetus here, where we use the laser to burn this trap fetus. So that's the thin membrane, and that's the trap fetus here. And we are using laser to burn that. And you can see the burn. You can see some bubbles coming in also. That's the color, and that's the stoppage of the circulation there. That's the laser and thermal energy that we are using here. And then there is also RF ablation. We have the point RF ablation or the umbrella. We prefer the umbrella, and we use this for 16-week fetuses and larger. 17G needle past the razor fiber. As you can see here, this was selective growth restriction with an hydropic fetus here. Same needle-guided procedure. We go to the cord insertion site, and with RF ablation, we cause the burn here, and this is a good procedure to do. If you have a larger fetus, then the better procedure to do is a bipolar cord coagulation, and I'll show you that in a minute. You need a trocar and a cannula. You puncture with Seldinger needle. You pass the bipolar cord forceps inside, and then that's how we do it. You may need to do a little bit of amnio infusion because the smaller fetus may have oligohydramnios and may be difficult. So that's the bipolar cord forceps. This is the cannula that you use through which we puncture. And what we do is catch the cord. Now that's the tricky part, because catching the cord can require some experience. And we burn for 10 to 30 seconds with 50 watts energy. And we burn the smaller fetus or the fetus you want to ablate with the bipolar. This is a better procedure because you are causing instantaneous suppression of flow between the two fetuses. Both in laser and RF ablation, the umbilical cord is not coagulated. So that's a potential dead space in which a donor fetus can exsanguinate, and the complications can be a little higher. But this procedure is technically very demanding, and you need to be good at that. You can see that to catch the cord can be quite challenging, and you need some experience with that. The last procedure I will show you is the complication rate, as I told you earlier, is about 20%. And of course, in the last procedure I want to show you is about the TTTS, where we go and ablate the AV connections or you ablate all the connections. That's called the Solomon technique, where you just ablate all the connections with a fetoscope, and that's the AV connections. You don't see the connection, it dips down, and that's how you will see it. So that's the Solomon technique. I will go through the theory part. This is a TTTS situation, and with a fetoscope, you push in the fetoscope into the desired site, and that's how you will see the connections. And then you identify the AV connections, and with laser you go and burn all the connections, and there's an 80% chance of salvaging at least one fetus, and of course 60% chance of salvaging both the fetus. And post-treatment, the Dopplers improve, the Leica improve. Complication rate, as I suggested, is 20%. I'll skip the theory part. And the last procedure, which has achieved great success, we haven't done any in India, but in most Western countries, is of course the tracheal balloon through the fetoscope. You put in a balloon for congenital diaphragmatic hernia, and that is placed at the trachea. This is on ultrasound. You can see the balloon. This causes the inflation of the lungs and allows the lungs to be inflated, and you can go in and deliver at 34 weeks. The problem being, of course, if the mother goes into premature labor, you should be around to deflate the balloon. Otherwise, this will cause hypoxia of the fetus. So guidelines are that for fetal therapy are that you need an accurate diagnosis. You should know the natural history of the condition. It should not be a condition which is going to regress spontaneously that you go and treat. You must give the risks of therapy to the parents and take the consent. You should have good neonatal care, experienced surgical team, because basically you're only prolonging the disease to be treated postnatally. You're not doing a complete correction. And of course, you must have a chromosomally normal fetus. So take-home message is that we must do careful ultrasound, do the chromosomal analysis, correct placement of needle. You need experience. You must avoid vascular injury both to the mother and the fetus. And if there is fetal distress, then you stop. So I thank you for a very, very patient hearing for all the four talks. And now I think we should open our forum for questions.
Yeah. Thank you, Dr. Lulla, for all the lectures, and I think you must be really tired and after this talking to all this time. I have a couple of questions. Shall I start with the first question then?
Yes.
Can you hear me? Yeah.
Yes, I can hear
you. First question is from our colleagues in Jaffna. They are asking how to measure the LICOA volume in multiple pregnancies. Probably I think they want to ask how to, is there a very standard way of assessing the LICOA volume like that?
Yeah. So we take the maximum vertical pocket always in multiple pregnancies. We don't do the amniotic fluid index. So we keep the transducer vertical. It should not be oblique, and it should be vertical, and you should measure the maximum vertical pocket in each of the pregnancies. So anything more than 8 is polyhydramnios, anything less than 5 is going to oligohydramnios, and less than 2 is severe oligohydramnios.
Yeah, that's great. I think that will answer their query. The next question, again, from our colleagues here in Colombo. The question is, what is the recommended AP diameter of the renal pelvis to call it abnormal? And if it is dilated, and when you decide that follow-up is necessary?
Okay, yeah, that's a very good question. Unfortunately, I couldn't go into too much details in 30 minutes. But when we are looking at soft marker screening, anything more than 4 millimeter in a transverse abdominal view is significant as pylectasis. But when we are looking to prognosticate for urinary tract abnormalities, then before 27 weeks, anything more than 8 millimeters is abnormal. After 27 weeks, anything more than 10 millimeters is abnormal. So 7 to 10 is the cutoff. And also there is a classification by the Society of Fetal Urologists. It's called the SFU classification. You look at the diameter. You look at whether there is central or peripheral callicial dilatation. So there are 2 grades. It's called urinary tract dilatation antenatal grade 1, where there is diameter less than 7 millimeters, no callicial dilatation. with normal renal parenchyma, normal LICA and bladder. Urinary tract dilatation stage 2 and 3, where there is more than 7 to 10 millimeter dilatation of the pelvis, and you have echogenic parenchyma, renal cysts, ureters are dilated, bladder is distended, and LICA is less. So this is urinary tract dilatation stage 2 and stage 3, where you need intervention. In stage 1, you may not need intervention. So these are the cutoff limits.
Okay, thank you. So that means if there is stage 1, do you still need to follow up? Or?
You will follow up every 4 weeks.
Okay,
And,
right.
okay.
Thank you. Then I come to the next question, which is about the DV Doppler, that is Ductus Venous Doppler. How to make the proper angle to obtain DV graph in Doppler? Probably I think they want to ask how you
technique.
Optimum graph.
Yeah. So in the first trimester, we usually do on the sagittal view. We keep the gate very small. It is 0.5 millimeter gate or less. And we do in the sagittal view, as I showed on the videos, you trace the umbilical vein into the abdomen, and where you see a bright spot. So if the vein is blue, it will suddenly become lightish blue to aliasing, and that's where you keep. You make the sweep speed so that you get only 3 waves in a graph, 3 or 4 waves, and you be careful that you're not imaging the hepatic vein, which is placed very close. So you will see that there will be reversal in atrial systole when you put it in the hepatic vein. And this you learn to recognize because you will see 2 waves coming in. You should see only 1 wave, which is the ductus venosus. The moment you see 2 waves, you know that you've got the hepatic vein. So essentially, in the first trimester, it's a sagittal scan. In the second and third trimester, we use the axial scan, and you follow the umbilical vein into the mid abdomen, and that's where you will see aliasing again, and you will see the ductus venosus.
And can the IVC, if you catch the IVC in that, can it cause
yes,
the artifact?
It will also. So hepatic vein and IVC will cause similar artifacts. So ideally you should move the moment you got reversal, move your gate a little bit, and you will get the typical ductus venosus, and you will avoid the artifact. So this you can learn after some time.
Okay, thank you very much. That's great. And I think we'll stop the questions from there because for the interest of time. So okay. I will hand over to Dr. Rupa for the vote of thanks. Please stay on.
Hi, good afternoon.
Thank you.
Dear Dr. Lulla, my dear teachers, colleagues, trainees, ladies and gentlemen, it gives me an immense pleasure in delivering the vote of thanks at the pre-congress workshop of annual academic session 2020 Sri Lanka College of Radiologists. At the time we were elected to the post, none of us ever imagined that the workshop or the annual academic session would be of this nature. However, despite all the restrictions and difficulties, we managed to do the pre-congress workshop as a hybrid conference. My sincere gratitude goes to Dr. Lulla, the speaker for the day, who accepted our request to the resource person of this event with a very short notice and delivering excellent lectures throughout the session. Sir, thank you for making this day meaningful. We hope that you will extend your generous cooperation in future for the betterment of field of radiology in Sri Lanka. We are regretful for our inability to present your token of appreciation as we used to do in the previous years. On behalf of all my colleagues in Sri Lanka, I wish you all the very best in your future endeavors. We hope that you and your loved ones stay safe in this hour of distress. The name GE had even very familiar with the radiology community in Sri Lanka due to their commitments and collaboration towards the excellence in service for the patient in need. At the time of uncertainty, to hold the pre-Congress workshop of annual academic session 2020, the dedicated team at the GE were encouraging us to make it reality by taking the administrative and financial burden to their shoulders. I really appreciate the way you encountered the challenge with a positive attitude. Thank you for all that you did to make this event success. In recognizing their social responsibility, the management of Sri Lanka Hospital offered their co-sponsorship for the workshop and paved with the smooth flow of the event. I take this opportunity to thank management and the staff of the Sri Lanka Hospital for their generosity. I extend my gratitude to the coordinator of regional centers for the support given in organizing the event to reach the target audience. Finally, my dear teachers, colleagues, trainees in radiology, your participation for the workshop is very much appreciated and valued. Without your presence, either in Colombo or peripheries, the whole program would have been waste in time and resources. Though we missed the opportunity to meet each other during the workshop, let's hope to do so at the inauguration of annual academic session 2020 on 7th of November. Thank you and have a pleasant evening. Thank you, sir.
Thank you. Thank you.